Good morning, good afternoon, good evening, everyone. Welcome to today's postgraduate course, New WHO Operational Guidance on the Management of TB in Children and Adolescents, a game changers to save young lives. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Your microphone should have been muted when you came into the meeting to avoid background noise. So if you unmute yourself and you have some background noise, please mute yourself. We'll check to make sure that everybody is muted when they come in. We encourage you to turn your webcam on if you can at time. We'd like also to ask you to change your display name to your name and country, if you can. In today's session, you'll have the opportunity to submit text questions and comments to today's presenters by typing your question into the chat. You can send your question via the chat at any time during the session, and moderators will collect your question and address them after with the speakers in the allocated Q&A sections. You will have the opportunity to intervene also by submitting a request to do so via the chat or by raising your hand. And the moderators will record your request and inform you when you can intervene at the end of the event if there's time. You can also provide feedback at the end of the event through the evaluation survey, which will appear directly in your browser. So once the meeting closes, you should see the question on your screen. Please complete the survey right after the workshop because the link will only be available for a short period of time. You will receive a certificate based on your attendance and the completion of the evaluation survey. Also, note that the event is being accredited by the European Board of Accreditation in Pneumology. Thus, you'll be able to claim CME point for your attendance. This session is being recorded, and the recording will be available to the public a few days after the session. Finally, it's my pleasure to inform you that today's chairs are Ben Marais and Kerry Vinay. Over to you, Professor Marais and Dr. Vinay.
Hello, everyone, and welcome to this Union postgraduate course. And thank you, Caroline, for the introduction. And really glad to see that we have almost 200 people online, and I'm sure that more will join. So welcome to this course. My name's Kerry Vinay. I'm a team lead in the Global Tuberculosis Program, and our team lead the work on ending TB among children and adolescents, as well as other vulnerable populations, and we are also working on TB, HIV, and comorbidities. Now, I'm very pleased to be co-chairing this session today with Professor Ben Marais, who I think many of you will know. And Ben is a paediatrician who works in the Paediatric Infectious Diseases at Westmead Children's Hospital in Sydney, Australia. And he's also the co-director of the Sydney Institute for Infectious Diseases, or Sydney ID, at the University of Sydney, among other qualifications. So Ben and I will be chairing the whole session. We have a great lineup of speakers. Now, just to briefly say before I hand over to Ben, I think many of you will know that WHO did release consolidated guidelines on the management of TB in children and adolescents in March 2022, along with an operational handbook. Now, the operational handbook does contain practical guidance on how to implement the WHO recommendations. And in fact, today's course is really aligned to the operational handbook, which covers the full cascade of care for children and adolescents, either with TB or at risk of TB. Now, the objectives of the course today are to provide an in-depth orientation on the practical implementation guidance on the management of TB in children and adolescents, which is included in the operational handbook that I just mentioned, which spans the entire cascade of care, as well as we want to share experiences and perspectives from some of the implementing partners. So really pleased to have some of those partners with us today. So I will hand over to my co-chair, Professor Ben Murray, and he will tell us a little bit about the speakers before we launch into the program. And again, welcome, and I really hope that you enjoy this postgraduate course. Thank you for joining us. Thanks.
Thank you, Kerry, and welcome everyone. We're very excited that you're able to join us for this Child TV training session or workshop. Just to say that we will keep things as short as possible with the introductions, because we want the emphasis to be on the content that the speakers will deliver and the questions that you may have. You've already heard that you can post your questions in the chat, and if we have time at the end of the event, we may open it for questions to the audience as well. We are really grateful for a wonderful lineup of speakers, which you would have seen on the program. We will introduce each of them as we go along, but we really think we will meet those objectives that Kerry outlined by having these updates from the field together with an overview of the recently released handbook. To get us going, we really just want everyone to be familiar with who's part of the call, and we have an icebreaker poll, which will really just give us an overview of where people are from and from what professional background they are. So I'm going to hand over to Caroline, and if people could just complete the poll, we'll give a short period of time, and then we will all have a good sense of who's joined us. Please answer both questions. I'll just give another 10 seconds or so for people to complete. Right, I think that's enough. People can continue to complete. Maybe just a reminder for everyone to please put their microphones on mute so that we don't have any interferences. But as you can see, we've got representation from all over the world today in our session. Very strong showing from our African colleagues. Thank you for joining us, but also from Southeast Asia. And I'm glad, being from the Western Pacific region, that they are represented as well. So thank you to everyone. That's a nice overview of who we have on the call and gives us context for the presentations as well. If we look at the type of organization that people work for, you can see that we've got representation again from all over, but mostly from national programs and from technical partner organizations, as well as research and academia. So I think that's enough for the introduction. We can probably stop sharing that so that we can move directly to our first speaker. So the first speaker is Dr. Sabine Verkuil, which, again, she probably needs no introduction. Sabine is a medical officer working on child and adolescent TB in the TB vulnerable populations, communities, and comorbidities unit in the global TB program at WHO. Every one of us will know her as the main driver behind the new child and adolescent TB operational handbook, and that's what she's going to focus on in a presentation. Over to you, Sabine.
Thanks very much, Ben. And thanks very much for that kind introduction. So good morning, good afternoon, and good evening to you all. So as Ben has said, I'll be giving you an overview of the new operational handbook on the management of TB in children and adolescents. Let me see if I can change the slide. There we go. I have no conflict of interest to report. And in this presentation, I'll be briefly looking at the global burden of TB in children and young adolescents, and then looking at the main programmatic gaps, and then taking you through the new guidance on child and adolescent TB, looking at the scope and target audience, the new recommendations in the guidelines, the consolidation of the guidance, the knowledge sharing platform, and looking at the structure of the handbook and the topics along the cascade of care. And then briefly to end, looking at some interventions that can be included in national strategic plans and funding applications. So these are the infographics from the 2018 roadmap, which have been updated with the data from the 2021 Global TB report. Unfortunately, the new report is not yet out and will actually be launched the day after tomorrow. So, but the data will have largely stayed the same, similar. So you can see from this slide that more than 1 million children develop TB every year, and they represent about 11% of the roughly 10 million people who develop TB every year. About 226,000 children died in 2020 of TB. The majority of them were young children under the age of 5. And the vast majority, 96% of these children, did not access TB treatment. And so we have huge gaps, case detection gaps, and also prevention gaps. And this graph on the left shows the case detection gap, which shows that in children, in all children and young adolescents under the age of 15 years, only about 36% were detected in 2020, and only 27% of young children under the age of 5 were detected. And so detected means reported, or diagnosed and reported to the national programs. And in addition to the case detection gap, we have a large prevention gap with only 1/3 of over 1 million eligible contacts under the age of 5 who did not, only 1/3 of those children accessed TB preventive treatment in 2020. So moving on now to the development of the updated guidance. WHO held the guideline development group last year in May and June, and the GDG, the guideline development group, reviewed evidence on quite a wide range of PICO questions using the GRADE methodology. That included the use of expert ultra, use of integrated treatment decision algorithms, treatment shortening in children with non-severe TB, and in children with MDR or rifampicin-resistant TB, the use of bedaquiline in children under 6, and the use of the laminate in children under 3 years. Then the GDG also looked at evidence on a short intensive treatment regimen for TB meningitis. Can I just ask everyone to keep muted, please? Thank you. And also on models of care for case detection and the provision of TB preventive treatment, looking at decentralization and family-centered integrated approaches. Then in March this year, the consolidated guidelines with an operational handbook were released at a UN press conference. And that's module 5 in the full series of guidelines and handbooks. And these guidelines really replace the 2014 second edition of guidance for national TB programs on the management of TB in children. And the links to both the guidelines and the handbook are displayed at the bottom of this slide. So the target audience of both documents include national programs, not just TB programs, but also HIV, primary healthcare, and maternal and child health programs, and also healthcare workers at different levels of the healthcare system. the education sector, and also NGOs, civil society organizations, community-based organizations, and of course, technical and implementation partners. And the objective is really to contribute to reductions in TB-related morbidity and mortality in children and adolescents, in line with the global targets of the Strategic Development Goals and the End-TB strategy, and also the high-level meeting on TB. And this figure on the right-hand side of this slide really depicts the cascade of care that is covered by both documents, really looking at every step from exposure to prevention, as well as diagnosis and treatment. And just to give you a summary of the new recommendations that are included in the guidelines with the practical implementation guidance in the operational handbook. These are on Expert Ultra, the use of Expert Ultra as the initial diagnostic test for TB and the detection of rifampicin resistance on all specimens. So that includes sputum, expectorated and induced, nasopharyngeal aspirate, gastric aspirate, and stool, rather than smear microscopy and culture and drug susceptibility testing. This is a strong recommendation with moderate certainty evidence for stool and gastric aspirate, and that was the evidence that this TDG reviewed, and low certainty evidence for sputum and very low for MPA. Then we have an interim conditional recommendation on the use of integrated treatment decision algorithms, which may be used to diagnose pulmonary TB in children with presumptive pulmonary TB who are attending healthcare facilities. This was based on very low certainty evidence. Then there's a strong recommendation on the use of a 4-month treatment regimen, so the standard regimen, but reduced by 2 months in the continuation phase, in children and adolescents between 3 months and 16 years who have non-severe TB. And we'll hear more from Dr. Megan Palmer about how to assess severity of disease on chest radiography. This recommendation was based on the evidence from the SHINE trial. Then we have a conditional recommendation on the use of a 6-month intensive treatment regimen consisting of isoniazid, rifampicin, pyrazinamide, and ethionamide, which may be used as an alternative option to the standard 12-month regimen. Please mute again. Thank you. So it's important to realize that this is an alternative option. And then moving, and someone is actually drawing on the slides, which is really interesting. But so moving on to the next set of recommendations. The next one is on the use of bedaquiline, which can be used now in children below 6 years. So that means that bedaquiline can be used in people with MDR or rifampicin-resistant TB of all ages. So an all-oral treatment regimen with bedaquiline may be used. This is a conditional recommendation based on very low certainty evidence. And similarly, in children with MDR and rifampicin-resistant below 3 years, the laminate may be used as part of longer regimens. And this is also a conditional recommendation. Then lastly, we have 2 recommendations on models of care. Firstly, that decentralized models of care may be used to deliver TB services to children and adolescents with signs and symptoms of TB and/or those exposed to TB. And similarly, family-centered integrated models of care may be used. And these are all in addition to standard models of care, both conditional recommendations based on very low certainty evidence. So I'm going to ask Caroline to launch the first poll, which is really about the recommendations that your country where you work or the country that you support is planning to implement. So you'll see all the new recommendations there. So the first one is on the use of Expert Ultra on stool and/or gastric aspirate, then the use of treatment decision algorithms, the shorter regimen for children with non-severe TB, the use of the short intensive TBM regimen for TB meningitis, and then the use of bedaquiline and laminate in children of all ages, and implementation of the models of care that are more decentralized and more family-centered and integrated. So you'll have to scroll down a bit if you can't see them all. And we currently have 286 people who can vote. So we'll give you a moment to cast your votes, and then we can see what the sort of the level of implementation or planning for implementation is in your countries. So currently we have 115 people who have voted, so that's going really well. And of course, you can also say all of them or none of them as the last two options. We currently have almost 150 people who have voted. If you haven't done so, please take a moment to cast your vote, and otherwise we will be ending it in order to save time for questions later on. So maybe we should, we're almost at 170. Okay. Great. Well, I think we can close it and have a look at the results. Thank you. So you should be seeing the results now on your screen. So the most commonly implemented one is the use of expert ultra on stool or gastric aspirate with 54%, and then the treatment decision algorithms in 47%. I'm just trying to see which one is the next one. Bedaquiline, 37%, decentralized and family-centered integrated models of care at 33%, but also the 4-month regimen for non-severe TB, the TBM regimen as well, but the laminate as well, and about a fifth of the respondents actually say that all of them will be implemented, which is great. And 3% say that none of them will be implemented. So I think we can close this poll now, and I'll continue. Thank you. Let me just close that as well. Thank you very much. So just to talk a little bit about the consolidation of the guidance that is included in the guidelines and the operational handbook. This slide really summarizes all the different bits and pieces of guidance that have been consolidated. So starting from prevention, but also TB screening, the 2021 guidelines, the BCG position paper, then the diagnostics module as well, the treatment module on drug-resistant TB, and the new ones on drug-susceptible TB and care and support. Then also infection prevention and control. And then, of course, a few of the recommendations from the 2014 guidelines were still validated and are still in place. Then also looking across to other guidelines, including HIV, nutrition, and the management of severe acute malnutrition in infants and children. So those are all the guidance guideline documents that have been consolidated. And then all of these guidelines, including this new module 5, are available on the WHO TB knowledge sharing platform. And you can see the link to the platform on the right. And there's also basically that platform pulls together the guidelines, the operational handbooks, as well as a training catalog. And we're currently working on developing training materials on a child and adolescent TB for both for a programmatic audience as well as for healthcare workers at the primary healthcare level. And these are expected to become available in due course in 2023. So just to show you the structure of the guidelines, I showed this picture before. This is really the cascade of care. So both guidelines and operational handbook start with an introduction in chapter 1. Then we have chapter 2 on screening and contact investigation. Chapter 3 is on prevention of TB. And then chapter 4 looks at diagnostic approaches. Chapter 5 on treatment of all forms of TB. And chapter 6 is on models of care. And then chapter 7 covers special situations that warrant some specific attention. And then the handbook has annexes with resources and tools. And I'll talk a little bit more about that in the next few slides. Just to give you an overview of the different chapters. So after chapter 1, that's the introduction, chapter 2 is on screening and contact investigation. That really looks at prioritizing household contacts, also a bit on planning and budgeting, some key implementation steps, and interesting approaches of facility and community-based examples of facility and community-based approaches. And we'll hear more about that from Martina Kazengi later this afternoon. Looking at screening, what kind of tools to use for screening child contacts and screening children and adolescents living with HIV. Also some algorithms from the screening handbook as well. In terms of prevention, we're covering BCG vaccination based on the BCG position paper from 2018. And of course, TB preventive treatment, looking at target groups, ruling out TB disease before starting a preventive treatment, also testing for infections, different options for TPT and follow-up and adherence. And then a short section on TB infection prevention and control based on the 2019 guidelines. And then moving to chapter 4, which is really about diagnostic approaches and of course realizing that diagnostic evaluation is the next step in the care cascade after screening, looking at diagnostic approaches for pulmonary TB, such as typical symptoms, history of TB contact, what are the findings on clinical examination, what are some of the atypical clinical presentations, and also going into detail on bacteriological confirmation, looking at the different sample types and the WHO recommended rapid molecular diagnostic tests. And it also covers the tests for TB infection, the role of chest X-ray, HIV testing, and of course the new integrated treatment decision algorithms for pulmonary TB in children. And these have been developed after the GDG, based on the same individual participant database that was used for the evidence review that led to the interim conditional recommendation. So the operational handbook contains new evidence-based treatment decision algorithms that countries can use to improve case detection in children. This chapter also looks at diagnostic approaches for extrapulmonary TB and for drug-resistant TB. Chapter 5 covers treatment of all forms of TB, starting with drug-susceptible TB, looking at the recommended regimens and also implementation considerations, including assessing eligibility for the 4-month regimen for non-severe TB, the use of ethambutol in the intensive phase, also some considerations for the new regimen recommended based on study 31, which is isoniazid, rifapentine, moxifloxacin, and pyrozinamide, which is recommended from the age of 12 years, and of course subgroup considerations. Then details on the treatment of extrapulmonary TB, dosing of the first-line medicines, which also includes dosing tables for the short intensive TB meningitis regimen, management of adverse events, and looking at treatment adherence, follow-up and monitoring. Then treatment of drug-resistant TB, how to identify children with drug resistance, and an overview of regimens, including the shorter all-oral bedaquiline containing regimens, the individualized regimens as well, and a practical approach to designing treatment regimens. and also the BPEL regimen. And this section is actually expected to be updated when the new drug-resistant TB guidelines come out, because the new recommendations from that guideline will also have implications for children and adolescents. Then there are some special considerations around TB meningitis due to drug-resistant TB, as well as TB-HIV co-infection. There's also guidance on dosing and formulations of second-line drugs with a fully updated dosing table in one of the annexes, Annex 6, and some details on monitoring as well. Then we also have a section on post-TB health, which looks at post-TB meningitis, post-TB lung disease, and also post-TB osteoarticular disease, and the associated quality of life. In terms of the models of care chapter, really looking at the key actions which cover integration of child and adolescent TB from the 2018 roadmap, and implementation considerations on how to implement decentralization, how to make services family-centered, how to integrate TB in other programs. It includes aspects to consider when planning for this, and opportunities for integrating TB in other services, and lots of examples of country experiences. And we'll hear from Eric Wobudea today of some of the experiences of the TB Speed project. It also covers private sector involvement and differentiated TB service delivery, and a short section on TB and health emergencies. Lastly, there is a chapter on special situations, which looks at the management of TB in children and adolescents living with HIV. And please mute again, because there seems to be some interference. Really following the cascade of care for these children and adolescents. Then a section on TB in pregnancy and the management of the newborn of mothers with TB disease. Then palliative care, care for adolescents. Also a section on TB in children with pneumonia, and management of children with TB and malnutrition. And just to give you a little bit more details on the handbook, of course, the content is based on existing WHO operational handbooks, but there's also a lot of newly developed content for topics which were not yet covered, and that includes diagnostic approaches, treatment, models of care, and special situations, and really a lot of practical guidance on each step in the cascade of care, with illustrations, examples, resources, and also the dosing tables. There's some color coding in the operational handbook. For example, the recommendations are displayed in boxes that are green, as you can see on the right-hand side, and then there's orange boxes with information, examples and resources, and then each of the chapters and some of the sections have key points or key messages in blue. And just to show you the different annexes, I won't go into too much detail, but just to say we have an annex with selected resources, an annex on tuberculous skin testing, sample collection methods. Annex 3 is really an overview, and then Annex 4 goes into the details of the standard operating procedures. Annex 5 is the treatment decision algorithms and the associated guidance. And Annex 6 is the dosing table for second-line medicines. And Annex 7 is an overview of options for neurocognitive and functional testing at the end of treatment for TB meningitis. So that brings me to one of the last slides, which is really on interventions that countries could include in their new and updated national strategic plans, and also in funding applications. That includes screening, including contact investigation and provision of TB preventive treatment, treatment decision algorithms, including rapid molecular tests and chest X-ray where available, and possibly studies to externally validate these algorithms, as well as operational research. Then the 4-month regimen for non-severe TB. Of course, this regimen may in the end work out much cheaper because it's a shorter duration, so less resources required in terms of drug supply, follow-up, but also for the families to travel to the healthcare facilities. But of course, in order to implement that, there will be a need for capacity building to really make sure that severity is assessed correctly, also chest X-ray interpretation, as well as access to chest X-ray. Then the all-oral regimens for drug-resistant TB in children of all ages, including bedaquiline and laminates, use of child-friendly formulations for prevention and first and second line treatment. TB-HIV care, including TPT again, but also antiretroviral therapy and cotrimoxazole. Then integrated and decentralized TB prevention and care services, and capacity building followed by regular monitoring, mentoring, and supportive supervision. So that brings me to the second and last poll on this topic, which Caroline, if you can launch that poll. And this really looks at the characteristics of the operational handbook that you as end users have found particularly useful. And that includes illustrations and implementation examples, the new evidence-based treatment decision algorithms, the detailed practical guidance on all steps of the cascade of care, the practical guidance on assessing severity, the dosing tables for drug-susceptible TB, and the new TBM regimen, and also guidance on constructing individual regimens for MDR and rifampicin-resistant TB, and then the resources, the standard operating procedures, and the updated second-line dosing table in the annexes. You are welcome to say all of the above or none of them, or you may indicate that you've actually not had a chance yet to access or go through the operational handbook. So we currently have 320 people who are eligible to vote, which is great. And we are currently at almost 150. So please keep going. And we're really interested to hear from you what you found most useful about the operational handbook. And we're also you're also very welcome to add further thoughts about the handbook, anything that you liked, but also things that you may have missed in the operational handbook.
We may have to cut it there, just so that we are on time. So if we maybe the final reflection.
Sure, we are almost at 200. Maybe we can close the poll when we're at about 200, or even I think it stopped a bit, 192. I think we can end the poll, Caroline. Thank you. Thanks. So you can see the results. There's lots of votes for the different bits and pieces, and 39% of you actually felt that all of the above were useful. And about a fifth of you have not yet accessed the operational handbook. So thanks very much, Caroline. I think you can stop sharing that, and I'll just move to the end of the presentation. I just would like to thank our director, Teresa Kazaeva, unit head Farai Mavunga, and Kerry, Annemieke, and Tiziana, who are also online with us today, and other colleagues from the Global TB Program, and of course all the experts who contributed to the development of the guidelines and the handbook, as well as the members of the Child and Adolescent TB Working Group. Thank you very much for your attention.
Thank you, Sabine. It's a wonderful resource to have. We'll have to move on to the next presentation. Just one quick question, which came from Brazil, and it was a question whether printed copies of the handbook will be available, and if so, when and how. But
Yeah, we had printed a limited batch for the recent regional consultation for the African region that we convened in September. We haven't yet printed further copies, and of course there's the electronic version that is on the WHO website, as well as the knowledge sharing platform where you can access. And we do know that so the French version is going to be available soon, and there's also translations into Russian and Spanish. The Russian one of the handbook is already completed, and the Spanish one is ongoing. But at this moment, we cannot share the printed copies, unfortunately. Thanks.
Oh, good. I'm going to hand over to Kerry to introduce our next speaker, and just to remind people to please mute and post your questions if you have any in the chat. Kerry, over to you.
Great, thank you very much, Stina, for an excellent presentation. Thank you, Ben. So yeah, we are going to move to the next presentation now, which is by Dr. Martina Kazengi, as you can see here on the screen. So Martina is a consultant with the Elizabeth Glaser Pediatric AIDS Foundation, and she was the technical director for the UNITAID-funded pediatric project called CAP-TB, which she will talk about. So I'd like to hand over to Martina, and yes, please keep any questions going in the chat. And yes, as Ben said, please keep muted. And I also noticed some drawing on the slide. If you could please refrain from any drawing on the slides, that would be really helpful. So over to you, Martina, and then we'll have a bit of time for questions at the end. Hopefully we'll have some time for that. Thanks so much.
Thank you very much to the chairs for the kind introduction, and thanks also to the organizers for the invitation to contribute to this postgraduate course. On behalf of the CAP-TB team, I will discuss today the evidence and the lessons learned generated through the project when it comes to the implementation of child contact investigation and TB preventive treatment in an African context. Let me start by declaring that I have no conflict of interest to report, and then by providing you a quick introduction to the CAP-TB project. This is a UNITAID funded project that was implemented in 9 African countries and in India between Q4 2017 and Q3 2021. For the scope of this presentation, we will focus only on the African countries, which, as you can see from the map on your right, are Cameroon, Cote d'Ivoire, DRC, Kenya, Lesotho, Malawi, Tanzania, Uganda, and Zimbabwe. The main objective of the CAP-TB project was to improve TB case finding in child and adolescents below 15 years of age. And in order to do this, a multi-pronged approach was deployed by the project, which included the introduction of pediatric TB systematic screening in different child health entry points, decentralization of the capacity to diagnose and manage pediatric TB to lower tier facilities, and then what will be the focus of our discussion today, the implementation of child contact investigation for all the TB index patients presenting at the project supported sites. Of course, the child contact investigation had not only the case finding component, but also a component focused on the delivery of TB preventive treatment. So let me also explain you a little bit about the data that I will show you today. The data that I will present have been collected through the project M&E system. The intervention data have been collected prospectively across all the project countries between December 2018 and June 2021 using specific project forms. I will also show you some results from a pre versus intervention comparison analysis. And in order to perform this analysis, we only utilize data from the 144 facilities for which we had both pre and intervention data available. In terms of population, we have focused on child contacts of TB patients identified at the facilities enrolled in the project. And when it comes to the eligibility for TB preventive treatment, we focus on the target population that were recommended by national policies at the time or when the project was kicked off. And this was represented by child contacts below 5 years of age and child contacts between 5 and 14 years of age if HIV positive. This is a slide that will describe give you an overview of the models of care that have been implemented through the project. So the models of care implemented were really discussed with the national TB program and agreed upon with the national TB program, also with the aim of identifying models that could be sustainable, and the implementation could continue beyond the project, so after the project would reach its final stage. In the majority of the countries, of the project countries, we managed to implement a community-based model of care for contact investigation. And under this model, the TB focal person would debrief the TB index patient on the importance of contact investigation, request permission for a home visit to see his contacts. And if the permission was granted, then community healthcare workers were assigned to this TB index patient and requested to perform home visits to identify the contacts and screen them for TB. And then the child contacts would have been referred to the facility either for TB diagnostic investigation or for confirmation of TPT eligibility and TPT initiation, depending on the outcome of the TB screening. In some countries, still is a minority, but still in some, only the facility-based household contact investigation model could be implemented. And under this model, the TB focal person was, again, debriefing the TB index patient about the importance of performing contact investigation and requesting the TB index patient to bring his contacts to the facility for TB screening. If the contacts were not presenting at the facility, then phone call follow-up was activated. And when the phone call follow-up was also failing, then household visits were activated. Sorry, let me move to the next slide. So this, on the table on your left, you can see, gives you a little bit of an overview of the models of care that were implemented across the different project countries, across the project duration. And the tick highlighted in green basically gives you the information on the context under which the project had to provide additional HR in order for the community-based model of care to be implemented. So the key message that I would like to bring here is that basically across all the countries and contexts where the project implemented community-based model of care, there was the need to either strengthen the existing community healthcare workers cadres that were tasked with the performance of contact investigation, or build the network of community healthcare workers tasked with these duties from scratch. So in addition to the provision of human resources, also in order to have a successful implementation of contact investigation through the community-based model of care, we also had to provide, the project had to provide food and transportation reimbursement to community healthcare workers, and as well, of course, refresher trainings, and followed by regular mentorship and supervision. And the table here on your right shows you a little bit, gives you an overview of the proportion of contacts that were screened either through the facility-based model or the community-based model across the different project countries. Other elements of the intervention that was deployed by the project that I think is worthwhile mentioning here is that we used under the project a child-adapted symptom-based screening tool that was also used for the child contact screening. And you can see here on the right the key elements of this symptom-based screening. We also deployed pediatric TB focused training both for the healthcare workers and the community healthcare workers. There was also quite some emphasis on the sensitization of caregivers on the importance of screening child contacts and the benefit of TPT. And last but not least, we also supported, whenever the National TB Program was in agreement, we supported the introduction of a shorter 3HR regimen for TB preventive treatment, which is available as a fixed dose combination and in a dispersible formulation. So now, before moving to the results, I would like Caroline to show the first poll. I think it would be interesting, before we move into the results of what we obtained through the project, to have an idea in the country where you work or in the context where you work, which is the model of care that is primarily implemented for child contact investigation. I think it would be, and you have few possibilities, among which you can choose is the community-based model of care. So the one that I just described, that is systematically implemented for all the TB index patients, a facility-based model where the TB index patients are asked to bring their contact to the facility, or a mixed model where the community-based household visits are performed only for a subset of TB index patients that are meeting some defined criteria. Let's wait, let's give some time to people to vote. I think that would be great if we can have a feedback from at least 2/3 of the audience, like if we can arrive to 200 would be great. I can see already that the mixed model seems to be the one that is most widely implemented. Okay. Can you please mute? Thank you. Okay, I wait just 30 seconds more, so please vote, cast your vote. It's the last seconds left. Okay, I think, Caroline, you can close the poll here. We almost reached 200, which I think is really good. And yes, I think we have a clear, you know, the model that is most widely implemented is clearly the mixed model, where the community-based household visits are only performed for a subset of TB index patients. And it would be good if you can put in the chat the reason why in the context where you work, this mixed model was chosen. Okay, thanks a lot. Let's close the questionnaire, and if I can, but I cannot in my screen. I don't know if you can close it on your side.
It is closed. I think you can close.
Or maybe a little. No. Okay. Let me move to the results. Maybe I just got out because I can't close the little window with the results of the thing on my screen. Let me just stop one moment sharing, and then get in again. Or it's only for me that is visible, the little window. You don't see the little window.
We can see clearly.
Okay, okay. So let me move forward. So let me show you first the contact investigation and case finding cascade for all the child contacts below 15 years of age. So across project intervention, about 45,000 child contacts were screened. And as you can see, 50% were below 5 years of age and 50% between 5 and 14 years of age. And among those, about 1,040 were diagnosed with TB. This means that, based on aggregated data across all countries, the number of child contact needed to screen to identify one child with TB was 43, which is quite low. And as you can see, there is, though I think it's important to note that there was quite some variability across the different countries when it comes to the NNS that we could see. let's now quickly go through the contact investigation and TPT cascade. And this time we focus only on the child contacts below 5 years of age. Among the about 22,000 child contact below 5 years of age screened, there were about 18,000 that were identified as eligible, and about almost 17,846 that were initiated on TPT. So we had a very good uptake of TPT among those found identified as eligible. And we also had a good completion rate, with 93% of the child contact terminating, reaching TPT completion among those initiated on treatment, on TPT treatment. And when it comes to the use of the 3HR regimen, this was implemented in Cameroon, Kenya, and DRC, and then in Zimbabwe we supported the use of this regimen as part of the national rollout. And there was overall a good feedback, a positive feedback from the healthcare workers on the use of 3HR regimen, based especially on the use of administration thanks to the availability of the pediatric formulation. And we had about 6,000 children initiated on 3HR regimen, with and among those about 97% achieved treatment completion. I will also show you quickly the comparison. We've also looked at the impact of project intervention on improvement of TB, initiation of TB preventive treatment. And as you can see, we looked at basically at the average number of child contact below 5 years that were initiated on TPT per facility and per month. And as you can see, the aggregated data across all countries show that the intervention led to a threefold increase in the number of TPT initiations, again with quite some variability across the different countries. And as you can see, the most relevant impact was identified in country 3 and country 7. And keep this in mind because we will discuss this a little bit more in details later. So before we move into the lessons learned, I would like to Caroline to launch the next poll questions. With basically we are asking you to tell us, in the context where you work, what are the major challenges that are faced for the implementation of contact investigation and TPT interventions, and to please tick the top 3 among those listed, which are, it's not a comprehensive list. If you think there is one or few more elements that should be mentioned, please write them in the chat box. But if you could pick the 3 top among those that we listed that are the most common that we came across, would be great. So it's insufficient human resources to support contact investigation activities, lack of or insufficient training, insufficient financial resources for the health system to support community-based contact investigation, lack of or suboptimal M&E tools, lack of awareness of child and adolescent TB in the community, and stigma and TB index patient reluctance to have her or his household members screened for TB. Let's have a look. So, yeah, I think it's quite evenly distributed, although there is really the human resources is emerging as one of the key challenges. And as far as I can see, also in general, the financial resources from the health system to support community-based contact investigation. So, okay, I would say you can close the poll now. And yeah, I think the results are confirmed. So really the insufficient human resources look like the most relevant, the most common, let's say, challenges, the challenge that is faced when it comes to the implementation, followed by the training and as well as the stigma and lack of awareness. Okay, thank you very much. These are very interesting results. I would suggest we move forward. As I was mentioning before, the country 3 and country 7 in our hands are the one where the interventions were most impactful in terms of improving the number of child contacts that were initiated on TPT. So we took them as case studies to try to identify the key elements that were really key for a successful implementation. And what has emerged is that certainly there are several elements that are related to human resources and management and logistical support that are really key for the successful implementation of contact investigation and TPT. And these, as I mentioned, are the human availability of human resources, the training, availability of SOPs that are clearly defined the roles, the TB focal person being allowed to supervise the child contact investigation activities. And of course, the transport and food reimbursement for community healthcare workers. The monitoring, there are also several elements that are linked to monitoring and evaluation, like the introduction of contact investigation and TPT register was found to be really useful, as well as the presence of strong, proper forms for community-based contact investigation, TB screening and referral to track the whole cascade, as well as, working with facility and MOH staff to establish contact investigation targets and engage both facility staff and MOH in reaching those targets. And then last but not least, as I mentioned quickly, also the sensitization of caregivers and communities was really important, as well as the involvement of community leaders, members in raising awareness about TB in the community. So coming toward the end, so these are the key lessons learned that we generated through the implementation of contact investigation and TPT under CAP-TB. What we learn is that rollout of TPT service is feasible, and the most challenging aspects remains the prioritization and the availability and mobilization of resources. Because, as it has emerged also from the pool results, the availability of resources are really key. What we need are dedicated human resources, dedicated resources for community healthcare workers, trainings, resources for management and supervision. And then beside the resources needs, is also important to consider that the introduction of a contact investigation and TPT register can also be instrumental. It really helped because it allowed us to monitor the whole contact investigation and TPT cascade throughout from start to an end, and to identify where children were falling off the cascade. And if you are interested in knowing more in details the lessons learned, I put here the report that CAP-TB has generated, the report on the lessons learned that is available through this web link. So contact investigation has been feasible under the CAP-TB project and is a key intervention for pediatric TB, both in terms of improving the case finding. So in our hands was a key gateway for both case finding, but also for access to TPT, as we just discussed. Reaching the child contacts and retaining them in care remains the most challenging part. And this requires careful planning of adequate resources and also strong processes for management and supervision of this intervention. And the introduction of the shorter 3-year age regimen was also feasible and was well received by the healthcare workers and caregivers for the provision of preventive treatment to child contacts. And with this, I come to an end, and I would like to thank the Ministry of Health and the National TB Program across all project countries, the child patients, their caregivers, and all the facility staff, the civil society organization and community care workers that have really made the community-based intervention possible, the CAP-TB country teams and global team across all the project countries, and then last but not least, our donor, UNITAID. Thank you very much for your attention.
Great, thank you very much, Martina. That's a really interesting presentation, and I can see some questions have been rolling into the chat. I'm just checking the time though, because we're right on time for the next presentation. So perhaps we could have one or two very quick questions before we go on to the next presentation. I can see one here from Eshetu Abdissa. How could chest X-ray screening be integrated into the community model? Can you answer that question, Martina?
Yeah. I would say, I think we really need to move forward with the digital chest X-ray machines and the portable. For this to be feasible, we really need new technologies, portable technologies to become more widely available and affordable, I would say, if I can make this comment, because in the context where we implemented CAP-TB, the access to chest X-ray was still too challenging to envision using them as a screening tool in community-based activities.
Maybe one other very quick question. Are there plans, and this is from Irungu Kuruga in Kenya, are there plans for a follow-up of those on TPT beyond completion?
Under the project, we did not. I know that some countries have this as part of the national guidelines, that there is a longer follow-up for children. Under the project, the follow-up after TPT completion was not part of the routine implementation. But I do know that some countries have it in their guidelines, which I think is valuable.
Yeah, thanks, Martina. That's very helpful. And there are a few other questions, and I can see people are responding to those questions in the chat. So I think please, if you have more questions, just post them in the chat. I'm sure Martina will endeavour to answer as many as she can, but I think we should probably move on to the next speaker in the interest of time. So I'll hand back to you, Ben. Thank you very much.
Thank you, Kerry. And yes, to encourage people to use the chat also to respond. And we will come back to some questions at the end of this session. But now I need to introduce Dr. Eric Wobudaya. Eric is a senior pediatrician at Mulago National Referral Hospital in Uganda. And he's going to talk to us about the TB Speed project. Eric, over to you.
Okay, thank you very much. Thanks for the introduction, and thanks everyone for joining in, and I'm glad to have this opportunity to share with you our experiences in the implementation of TB Speed. And in this presentation, I'm going to be moment. Okay, so in this presentation, I will be focusing on two areas. I'll be talking about the aspects of decentralization of childhood TB diagnosis and the use of alternative specimens in children. These are lessons learned from the TB Speed project. Eric over there presenting on behalf of a big group, the TB Speed Decentralization Study Group. And I want to thank you very much for giving us an opportunity to speak to you concerning this. I have no conflict of interest to declare. So the first aspect I'll be talking about, let me first give some aspects of the decentralization of TB services, our TB Speed experience. I will be able to first of all get to thinking about, we know that WHO has recommended decentralizing childhood TB services and diagnosis. However, we know that there's limited data in terms of specifically focusing on answering the question, what do we decentralize? How do we decentralize? How do we decentralize? And to which level of care we decentralize? We have limited information in terms of cost effectiveness and effectiveness of these areas. And the TB Speed project attempted to answer some of these questions. And I've got to say that I'll be sharing some of the results, but some of the information is still pending. We know that in the context of decentralization, we still have a number of challenges. And one of the major challenges that we take into consideration, and that are contributing to the low finding of TB cases in children, include challenges of sample collection and diagnostics. We know that most of the respiratory samples from children have low yield. And not only that, this also coupled with the difficulty in obtaining some of those samples, especially the quality form. In some of the countries, the gene expert machines are not widespread, and therefore the access to diagnostics is limited. We also know that there's an issue of capacity in terms of practice and clinical skills regarding TB screening. Also the capacity for the proper diagnosis, access, and even skills for quality chest X-ray interpretation is a major challenge. And the structure of health systems in a number of countries do have a challenge in terms of decentralized services, whereby most of the TB diagnosis and treatment are centralized either at the secondary or the tertiary levels. In the TB Speed project, in terms of the general overview, the objective that we had was to assess the impact on childhood TB case detection of decentralizing a comprehensive childhood TB diagnosis package, and also wanted to compare the efficiency, feasibility, and acceptability of two decentralization approaches that we were testing. TB Speed project was implemented in a number of countries, 6 countries, and that was Cambodia, Cameroon, in Cote d'Ivoire, Mozambique, Uganda, and Sierra Leone. And in each of the countries, we implemented this in 2 districts, and these districts were selected together with the national TB programs of these countries, and were selected on the basis of the capacity in terms of the need in every district needed to have at least a hospital, and at least four primary care levels, which that hospital serves, with minimum human resource that can be able to do a minimum diagnosis in children. And each of the countries, one of the districts was randomized to either one of the strategies or the approaches that I'm going to be showing you in the next slide. So in terms of the structure that we had, so we had 2 aspects of the intervention. We had intervention at health system level, whereby we were testing the decentralization approaches. And then we also had the intervention at the patient care level, what I call the childhood and the comprehensive childhood TB diagnosis package. Now, if I first look at the health system level, we had 2 approaches in terms of testing the decentralization. One of them is what we call the district hospital or DH focus strategy or approach. In this approach or this district, the PHCs in that district only conducted TB screening and only referred children to the district hospital for further TB assessment. In that district, at the district hospital, there was TB screening. There was also collection of samples and microbiological diagnosis, clinical evaluation, and chest X-rays were done. Somebody mute, please. In the PHC focus strategy, what we call the comprehensive package, which included expert TB screening, collection of NPA and stool, and testing on expert, clinical evaluation and chest X-ray interpretation was done at the district hospital. While at the PHCs, in the PH focus strategy, there was TB screening, there was collection of samples of NPA and stool and testing, and also clinical assessment, and the diagnosis was done at that level. Children were only referred to the district hospital for chest X-rays, where indicated, or where children had a severe condition with the indication for referral. So those were the 2 approaches that we're testing. At the patient care level, where we're doing clinical assessment, the comprehensive childhood TB diagnosis package consisted of systematic screening, whereby we were screening children entering at the OPD, all sick children entering at OPD under 15 years of age were being screened for TB. And those that were presumptive TB were evaluated. There was a clinical evaluation for TB in those patients. And all those children with presumptive tuberculosis had microbiological diagnosis performed on them, whereby a stool sample and NP was collected, and these were tested on expert ultra. We also, part of this package was optimized chest X-ray reading, whereby chest X-rays were digitized. The healthcare workers were trained on chest X-ray reading, and then there was a contact assurance system for being able to ensure that X-rays are optimally read. So that was the comprehensive child TB diagnosis package that we implemented at those levels. So in terms of some of the aspects of implementation of decentralization, we had two phases. We have the observation phase, and then we have the intervention phase. During the intervention phase, just before we implemented all the package that I've been able to explain, we had to set up. We had a setup phase whereby we had to work with the NTP to engage the NTP with also setting up study teams. We have provided equipment, and we also established sample flow and transport systems, how the samples would flow, and also established test X-ray systems that use test X-ray flow systems. We provided digital X-ray machines for the hospitals where these were not available, and where they were, we provided what we call DR plates. These are plates that digitize chest X-rays, and we conducted training for all staff, both in the study and also in TB diagnosis. During the intervention phase, we did conduct supportive aspects, and the first one, we conducted structured support supervision, where we supported the healthcare workers in being able to effectively implement implement the aspects of the study. So they were able to make sure that the screening is done appropriately, documentation done appropriately, and all the recordings are done accordingly. So that was in the structured support supervision that we did provide. Then we also conducted clinical mentoring, and this was targeted to provide clinical skills to healthcare workers, specifically in terms of being able to make a diagnosis. And here we're focusing on clinical diagnosis and also being able to interpret chest X-rays. We also set up a chest X-ray quality control system, whereby we set up a system to be able to ensure that the X-rays that the clinicians are reading are consistent with the tuberculosis, or what the clinicians were reading was consistent with what the natural reader was able to read. So we're comparing those results, and remember that the clinicians did not wait for any validation to be able to make a decision on X-rays. They did make a decision, and we only discussed with them later on concerning what came out of the X-ray reading in terms of training. And we did that at the clinical mentoring sessions. We also ensured there was coordination throughout the intervention phase, where we had different meetings, both at local and national level, to ensure there was consistency and be able to sort any issues that were rising up when we're implementing the decentralization. Now, let me quickly get to this. So I think, let me first make a pause. I think I needed to have us to get a feel at this point in time before I move forward to my next slide. And I want us to have, I want to just ask can we be able to share the first poll? That is I want to get a poll from the participants on what level of decentralization is happening in your country. At what level are you decentralizing services in your country? So we just want to know, have an idea of what's the lowest level, and then just also what are the major challenges that you're getting in terms of when you're implementing decentralization at that level at which it's being decentralized. So we have 327 people who are eligible to vote. So let's see the polls going. And I can see we have quite a high number of decentralization happening at the primary health center level, which is the lowest level. We see a few people at the health post, and we also see at the community level, the decentralization there happening. Okay, if we can make the poll of about 400, we'll be able to, that will give us a good representation. So the primary center level is the commonest there, and in terms of the major challenges in diagnosis, apart from the sample collection, diagnostics seems to be the highest on the list. And we have chest X-ray and clinical skills being at the same level, at high level. So let's give it a few minutes and a few more votes in coming in there. So can we? Okay. All right. So I think 2 minutes. I mean 2 seconds. A few seconds. All right. I think let's share those at that point. Now, okay. So you can see that the US level, most of your countries at the primary center level, and the major challenge at that level is sample collection and diagnostics. Okay, thanks very much. And then X-rays, and I can see clinical skills also an issue there, and that is good. So thank you very much. Let's move forward with the presentation. So let me then share with you some of the findings that we've got in terms of. So looking at our first objective, try and see what's the impact on of our intervention of TB case detection. And we're comparing the before and after. So in terms of the before, we looked at 12 months, so I didn't give you the details. 12 months of data collection for 12 months. And so we're looking at the OPD attendance and look at TB cases before. And then also look at 12 months after the intervention. And as you can see on this slide, before in the observation phase, there were about 250,000 OPD attendances under 5 years. And after, during the intervention phase, we had about 180,000. And number of TB cases, before our intervention, had 217 cases, represent 0.08% of the OPD cases. And after intervention, we had 406 cases, representing 0.23%. And that was nearly a threefold increase in TB case detection. So that gives us that feeling that shows us that really decentralizing TB services and being able to implement intervention was able to increase the TB case detection by about threefold. Breaking it down by country, so you can see a before and after. Across all the countries, there was largely an increase in TB case detection after the intervention compared to before. But you can observe 2 or 3 key countries whereby there was a major change, and that was in Cameroon, whereby we had quite a significant increase. And then we also had Cote d'Ivoire, which showed quite a very high increase in terms of TB case detection after the intervention, and also Sierra Leone. Some other countries, we see it was a modest increase, but overall, we see it was an increase in TB case detection after we did the intervention. When you look at this in terms of the approaches, or what we call the strategies, the DH-focused strategy, whereby the district hospitals are the ones which that could perform the diagnosis, and the PHC-focused strategy, whereby even both the district hospital and the primary center levels were making the diagnosis. We observed that overall, as I've said, there was an increase, but in terms of when we break down, we realized that the district hospital focused strategy, the increase was much higher than we had a significant increase from 80 TB cases before to 302 after. About 4 times increase, and a significant difference there. And the PHC focus, there was a modest increase, really a small increase there, which still was significant, as you can see. When you look at country level, in terms of the countries, the PHC focus strategy, there was no, the change, the differences was slight in most of the countries. But in terms of the DH focus strategy across all the countries, obviously we clearly see a big difference in terms of the TB cases detected after the intervention. That's the overall. We can discuss that further again. But look at now. Let me just show you a little bit about this cascade from screening to diagnosis during the intervention phase. So in terms of the OPD cases, we are comparing between the district hospital focus approach and the primary health center focus approach. And we see that in terms of screening, there was no significant difference in the screening rates between the two approaches. And in terms of presumptive rates, similarly, the presumptive rate was not very significantly different. What you can take note of is that the number of TB cases detected was much higher in the district hospital approach compared to the primary center focus approach. And also, when you take note of the numbers diagnosed, in terms of if you make a proportion, the numbers diagnosed from the BH focus strategy is much higher in terms of even proportion. And that is what we found in this in our approach. Moving forward, just a few challenges that I wanted to share with you as we implemented. Amidst this implementation, there are some challenges in terms of screening. We got this feedback from the healthcare workers that some of the screening questions were complex to understand, and they required to be phased in two phases. You remember, most of the times the screening question like cough. The question is, have you coughed for 2 weeks, or have you had fever for 2 weeks? That question seems simple, but turned out to be quite complex. So it was easier to ask, have you coughed? Then if they said yes, then you say for how long? But if you put it across, many times it came up like a stigmatizing question, suggesting the healthcare that maybe the parents were not paying attention to their children and they're taking too long to be able to bring them to hospital. The other one was stigma. There was stigma in terms of screening. So those screening questions of, do you have TB in the waiting area was stigmatizing some of the areas, some of the places. Presumptive rates were not being documented. In terms of the NPA collection and sample, and as I've seen, a number of you have been able to express this as one of the challenges. We had a challenge in terms of sample volumes. We'll be able to show you the next slide about feasibility. And also sample collection. There were difficulties collecting two samples. Again, I'll show you in some of the next slides. And the challenges of returning to bring samples for stool. And so the feasibility was a challenge. And also had issues of power in terms of sample testing. The lower the facility were, there were challenges of power stability, and so there were more errors in terms of results. And also transportation of stools to the district hospital from the PHCs was quite challenging. And so the turnaround time turned out to be quite long. And also the transportation of stools, especially for stools, the long distances and the poor transportation conditions were quite a major challenge. And so some of the roads were impassable during some of the seasons, and that was an issue in transporting of stools. In terms of chest X-ray performance interpretation, the chest X-ray machines broke down quite often, and sometimes the radiographer was unavailable. You start with the radiographer, when you move down a few months, they actually leave or they go for training. And there were challenges certainly with the quality and calibration, and some of the PHCs followed had quite significant delays in having reports. The chest X-ray EQS system was challenging to operationalize some of the countries to be able to get central readers. We failed to get some places readers at the national level to be able to do the quality controls. And internet connectivity was really a major issue in being able to transmit the pictures in chest X-ray interpretation. The referrals, we had issues with referral in terms of transportation, the distances at the time, and some of the parents would actually refuse. They would actually refuse to move to go to the next level. And where they wanted to move, the communication with the next level was quite challenging. And so sometimes they would arrive and they are not expected, and there were quite some delays in some of those. The human resource was a continuous issue in terms of sometimes the staff are transferred or they're rotated, and so you come back and you find that they are no longer there. And so that was a major issue in terms of implementing. And so you have got to train again, and the motivation was low in some of the places. And especially in rural areas, the issue of timekeeping was quite a major issue, and sometimes the patients would find it challenging to wait. So those are some of the challenges that we observed as we decentralized. Let me now quickly be able to share with you some of our experiences on using of alternative samples for TB diagnosis. Now, we did have, and here I'm sharing on 4 studies. We did a decentralization. So we had the decentralization study at the OPD, we had the pneumonia study, the severe malnutrition study, and then the HIV study. So I'll give you a few quick snapshots of these. So in terms of the decentralization study, the population, as I already mentioned, these are 6 children who are presenting at OPD, and the NPAs were being collected by the nurses immediately after triage, and we're using an aspiration machine that was battery operated. And the samples were being tested on site using expert ultra, either on G1 at PHCs or the G4 at this hospital. The stools were collected by the mothers, and these containers are provided to them at the time of enrollment, and they were allowed to bring back the stool the following day. And these stools were not supervised. The collection was not supervised. At the primary centers, the samples were transported to the hospital for testing or for processing. At the district hospitals, the stools were actually processed at this hospital using the TB speed optimized sucrose flotation method, and these were tested on experts. If you look at the population pneumonia, we basically did our population was children with severe pneumonia at the tertiary hospitals. This was done at the tertiary hospital, and these samples were collected by the nurse within 24 hours of admission, and we monitored oxygen saturation. So those were hypoxic, we did not collect, that means oxygen below 90. And we also collected using the suction machine, which was battery operated. And we also collected data on adverse events, and we tested these samples on expert ultra on G4. And this was at the hospitals. For the stools, again, we depend on the mothers to collect for us the stool from these children. We provided them the containers, and again, the stool was not supervised. And this was tested using this. The stool were processed using the TB speed optimized sucrose flotation method, and again, we tested this on expert ultra. For the children with severe malnutrition, again, from the tertiary hospital, the NPA was collected in the same way we did collect for children with severe malnutrition, with severe pneumonia, within 24 hours using battery operated machines. And then also we tested this on G4. And also the stool samples were collected and tested in the same way at the district hospital, at the tertiary hospital for children with severe malnutrition. Again, also for the children severe with HIV, these were mainly outpatient children. They were aged 1 month to 14 years, and they were children with presumptive TB. We collected one nasopharyngeal aspirate from them and 2 years or 2 experimental sputum samples from each of these children. And then we also collected one stool sample from these children, and this was collected as soon as the children were able to produce the stool. So here I give us some of the feasibility and the yield for each of these studies. So we see that and I'm breaking down this by the approach. The district hospital.
Director, to say 2 minutes to go.
2 minutes left. Okay, so here I can be able to get our team members to be able to take note of the feasibility here. So take note of the numbers in. You can see feasibility was over 90% for the NPA, and you can see that also for the stool, the feasibility was lower, 80% the DH focus and 60, almost 70% in the PHC focus. So you can see lower feasibility, and also in terms of TB detection, it is lower on the you can see that it is lower at the PHC focus generally compared to the DH focus, but at least at 2.3% was the yield for the NPA and 2.5 for the stool. It's not very different for the students severe pneumonia, HIV, and NPA study and HIV. NPA feasibility was good, over 90%. So you have good feasibility for NPA, success, and also testing was at high level. So good feasibility there for NPA. And for stool, it is again at the district hospital or the tertiary level, it is good. 80% for the pneumonia, about 90% for the severe malnutrition, and over 80% for HIV. So feasibility for stools are much higher or much better at the higher level, and over 80% stools were collected in terms of feasibility. So feasibility is much better at that higher level. In terms of yield, again, this is on average, you can see the yield is generally low, as you can see, across all these studies. So in terms of conclusion, I want to quickly conclude and say that in terms of decentralization, decentralized TB diagnosis at district level or lower capacity with capacity building equipment and making diagnosis tools available increases case detection. And triage-based screening is highly feasible and this for identification of presumptive TB cases. And the DH focus approach, despite the challenges of referral, had better case detection in our experience overall than the PhD focus approach. And we still under doing cost-effective analysis to be able to provide this, and these results will be able to be shared in the near future. In terms of alternative samples, the NTPS sample collection and testing is highly feasible in all severely sick children, and stool sample collection testing is feasible in all these children, but it's a little bit more challenging. The yield is generally low, as you saw in our results. So with that, thank you very much. I want to appreciate all our technical, all our the NTPs that we worked with and all technical partners. And certainly, I want to thank all of you for listening to me, plus our funders, as shown on that screen. Thank you very much.
Thank you, Eric. That was a wonderful overview, and it's great to see data coming from the field. Clearly a complex area, but I think there's a wealth of information to assess, and I'm sure you'll be doing that in the coming weeks. I'm just mindful of time.
Thank you.
We want to have a quick 5-minute break so people can just stretch their legs, but please continue to post your questions on the chat. And Eric, maybe if you could just answer any questions there. Then I'm going to ask everyone to be back at 1:40, so in 5 minutes time, for us to start with the next session. But thank you for everyone, all the speakers for our first session. We'll see you back in 5 minutes time at 1:40 sharp to start.
Okay, well, welcome back everyone to this Union postgraduate course on the operational handbook and implementation considerations for the management of TB in children and adolescents. I hope you've managed to stay with us. We had a very interesting session just earlier. We can see someone's screen with a document. Can we just stop the screen sharing, please? Because we're going to introduce the next speaker, which is Dr. Megan Palmer. Megan is a pediatrician and a clinical researcher at the Desmond Tutu TB Centre at Stellenbosch University in Cape Town. She's worked in the field of pediatric TB clinical research for the last 8 years, focusing on diagnostics and then more recently TB treatment trials. And Megan and her co-authors have co-authored the Union's updated diagnostic chest X-ray atlas for TB in children, which was also launched in March 2022. So I might hand it over to you, Megan, just so we can keep on time. And please keep posting questions in the chat to all of the colleagues who are online. Thank you so much.
Thanks very much, Kerry, for that introduction. Can you see my screen?
Yes, we can.
Okay, great. Okay, so thank you for the introduction. My name is Megan, and I'm going to be presenting on assessing radiological disease severity using chest X-ray in children and adolescents with TB, with the aim of supporting access to shorter treatment regimens. And the outline of my talk will be to give a little bit of background into treatment shortening, and then to go through a series of X-rays and try and keep it quite practical. And then I hope at the end we'll have time for a few poll questions where the audience can have a chance to assess disease severity on chest X-ray. And I have no conflict of interest to report. So one of the new recommendations in the WHO updated guidelines, which were published earlier this year, is around treatment shortening, with the recommendation that in children and adolescents between 3 months and 16 years of age with non-severe TB, without suspicion or evidence of MDR or rifampicin-resistant TB, a 4-month treatment regimen should be used. And this treatment regimen uses standard first-line TB drugs at standard doses, but with 2 months shorter continuation phase. Notably, non-severe TB is defined as peripheral lymph node TB or intrathoracic lymph node TB without airway obstruction, uncomplicated TB pleural effusion, or porcibacillary non-cavitary disease confined to one lobe and without a miliary pattern. And although the focus of my talk is going to be on how we use chest X-ray to classify disease severity, I think it's just worth noting that lack of access to chest X-ray does not preclude the use of a shortened treatment regimen, and you can refer to the guidelines in this regard. So where did this come from, this new recommendation to recommend shortened treatment? It was largely based on evidence which was generated from the SHINE trial, And SHINE was the first TB treatment shortening trial to be conducted in children and randomized 1,204 children with minimal or non-severe TB to 4 versus 6 months of treatment with follow-up to 72 weeks. And the results of this trial were published earlier this year in the New England Journal of Medicine, and they showed that the 4-month treatment arm was non-inferior to the 6-month treatment arm. Obviously, a key methodological aspect of this trial was the definition of disease severity, as children with severe disease were not eligible to be enrolled. So prior to the SHINE trial, there really wasn't empirical evidence on disease severity stratification in children, and the disease severity classification used in SHINE was based largely on an understanding of the pathophysiology of childhood TB and the theoretical framework for disease severity classification outlined in this article, which was authored by Catherine Wiseman and colleagues, but also obviously being cognizant of data from adults, which has shown previously that cavities and extensive disease, so extensive involvement of the lung parenchyma, correlates with higher bacterial burden and delayed culture conversion rate, and probably poorer clinical outcomes and higher relapse rate. So prior to enrollment on the SHINE trial, severe disease had to be excluded using the chest X-ray. And the definition of non-severe radiological disease on SHINE is in this block here, and really it aligns with what is in the updated WHO treatment guidelines. So non-severe disease included uncomplicated lymph node disease, isolated gone focus, simple pleural effusion, consolidation that involved less than a lobe with no cavities and no miliary infiltrates. So now I'm going to move on to looking at a few chest X-rays, but before we start, just a few sort of disclaimers. The aim of this chest X-ray evaluation step in this presentation is really to look at disease severity. So I'm not going to be focusing on whether we think the chest X-ray looks like TB or not. We're going to really focus on how to classify disease severity on the chest X-ray. And I just want to remind everyone that it's important to always have a systematic approach to chest X-ray interpretation. I'm not going to go through each of those systematic steps with each chest X-ray today, but remember to always do that so you don't miss things. And this systematic approach should always include an assessment of the technical quality of the film. So chest X-rays are the most widely available imaging modality, particularly in TB endemic areas, but we do realize that there are limitations to chest X-rays, and I think it's important to acknowledge those up front. So a chest X-ray is essentially a 2-dimensional representation of a 3-dimensional space, and there are inherent limitations to what can be seen on a chest X-ray. The sensitivity and specificity of X-rays are suboptimal when compared to advanced imaging modalities such as CT chest, but of course these are often not available. And then we must acknowledge the intra and interreader variability in chest X-ray interpretation. I think it's really important to try and standardize how we read X-rays, but even with standardization and training, we know that there will always be some disagreements. So the approach that I'm going to outline in the next few slides when we go through some chest X-rays, it has been taken from the updated Union Diagnostic Chest X-ray Atlas for TB in children. And so I think it's really worth visiting this site and downloading the PDF version of this atlas so that you can review what we discussed today and see some more chest X-ray examples. Recently, in the last few weeks, the union has also launched this here on the right-hand side of your screen, this online image library, which has some additional images in addition to the chest X-ray atlas, which are also depicted, classified by disease severity. So it's another resource for training and upskilling yourself. Okay, so now we put ourselves in the position of being a healthcare worker, sitting in a clinic in a TB endemic area, and you have a child in front of you who you've decided, using perhaps the clinical algorithms in the WHO guidelines, you've decided that they have TB. The child has non-severe disease clinically, so it's clinically stable, and you were able to collect respiratory samples, which was smear negative. And now you're looking at the chest X-ray because you'd like to decide whether you should treat for 4 months versus 6 months. So essentially, you should really be using the X-ray at this point as to exclude severe disease. So to exclude the features of radiologically severe disease. And I would recommend going through the following steps. So ask yourself, is there significant airway compression or deviation? Is there consolidation that involves the entire lobe or more than a lobe? Are there cavities? Are there miliary infiltrates? And is there a complicated pleural effusion? And if you say no to all of the above, then you have essentially excluded severe disease radiologically, and you could consider the 4-month treatment regimen. So just by way of clarification, when you're talking about significant airway compression, This obviously includes seeing the airway compression or deviation, but sometimes it includes seeing just the consequences of it. So I will show you a few slides to demonstrate this, but sometimes you can see the consequence of the airway obstruction, such as unilateral hyperinflation or collapse, even when the airway obstruction itself may not be well visualized. Then a quick note on the consolidation aspect, because this can be a bit tricky. So you're going to need to be able to decide if the consolidation that you see involves less than a lobe or an entire lobe or more. And this infographic over here that you can see has come out of the atlas, so you can access it there, or perhaps you have one of your own, but I would suggest having something like this handy, because this just helps to remind you of the outline of all the lobes of the lungs, so that you can use this to decide on the extent of disease on the chest X-ray. And then largely a note about the pleural effusions. So a complicated pleural effusion in this stage is classified as an effusion that is loculated. So that means it's become organized. This is often an empyema, although that's not a radiological diagnosis. It may be associated with a pneumothorax, or there may be an effusion with underlying lung involvement, so underlying consolidation. And all of those would make the effusion complicated and severe. Okay, so let's look at our first chest X-ray. So we know that children usually get TB after inhaling the bacillus from a close contact who may have TB disease. And the bacillus travels down the airways into the alveoli and then gets into the lung parenchyma, where there's a parenchymal reaction. And this is often the very first radiological feature of primary TB in children. And you can see here a very nice gone focus. They're not normally this neat and tidy as they are on this chest X-ray. So if you go through your list here, you'll note in this chest X-ray, there's no airway involvement. This area of parenchymal reaction or consolidation that you can see here is minimal. It's less than one lobe. There are no cavities and miliary infiltrates and no complicated effusion. And this really is early and non-severe disease. It's also a transient chest X-ray pattern. The child's normally clinically quite well, and so it's actually quite uncommon to see this pattern on chest X-ray. So from that parenchymal reaction, the bacilli get carried via the lymphatics to the intrathoracic lymph nodes. And really here we have an example of a large left perihilar lymph node. And we know that intrathoracic lymphadenopathy is really the radiological hallmark feature of pediatric TB. And what I want to just highlight in this chest X-ray is the patency of the airways. So you can see the airways are open. The lung parenchyma does not look involved, and there's no complicated effusion. So this is really uncomplicated lymph node disease and would be classified as non-severe. So here's another example. This child, you've decided to treat this child for TB because you think there's a right perihilar lymph node here. And let's just look at the X-ray for disease severity. Looking at the airways, you can see they appear patent. The area of perhaps consolidation on this side is minimal, involving less than a lobe with no cavities, miliary infiltrates, or complicated effusion. And I do want to just note that this is a bit of a poorly inspired form, but this is another example of uncomplicated non-severe TB disease. Okay, the most obvious feature in this chest X-ray is this area of segmental consolidation. So you can see here this area, this opacification, which is sitting in the right upper lobe. And you can see it nicely on the lateral here. You can see the fissure very nicely. And there may be a suspicion of being lymph nodes in the paratracheal or perihilar region, but they're difficult to see. But really to highlight in terms of disease severity, you've got opacification here involving less than a lobe with none of the other features of severe disease. So this child could be treated for 4 months. Okay, so we know that lymph node disease, the examples I've shown you thus far, were uncomplicated, but of course, enlarged lymph nodes can cause complications. And one of the major complications is compression of the airways. And this is an example of a chest X-ray where you can see paratracheal lymph nodes, so these lobulated opacities next to the trachea and the perihilar region, but really to highlight this left main bronchus. And if you follow the left main bronchus, you can see this area of narrowing over there, where that bronchus has been squeezed between 2 enlarged lymph nodes. And so this would be complicated lymph node disease, and this child should be treated for the full 6 months. So I mentioned earlier that sometimes you can see the consequence of airway involvement when you don't actually see the airway involvement itself. And this is a very classic but uncommon chest X-ray feature. So this is what we call a check valve or ball valve effect. And what happens here is there's partial obstruction of the airway on the left, which allows air into the left lobe, but doesn't let into the left lung, but doesn't let it back out again. And so you get air trapping. And this left lung, you can see, is very hyperinflated and very dark because it's got a lot of air in it. The diaphragm is pushed down and flat, and the mediastinum has been pushed across. So this is another example of complicated lymph node disease and would be classified as severe radiologically. And you can see the impression of lymph nodes on the left here. Sometimes the airway obstruction actually blocks the entire airway and you get collapse of a lobe. So if you look behind the heart here, you can see this white triangular shadow showing left lower lobe collapse. And because this involves the whole lobe and is a consequence of airway obstruction, this is also complicated lymph node disease and is severe. Okay, well, the first X-ray I showed you showed an isolated or a non-severe and uncomplicated gone focus. Here is a gone focus that has not been contained by the host or not been treated with central cavitation. And whenever you see a cavity on a chest X-ray, you should classify it as severe disease. There's also extensive consolidation bilaterally on this chest X-ray, which also makes it severe, and I think narrowing of the left main bronchus. Looking at pleural effusions, this is an example of a simple pleural effusion. So this is seen more commonly in adolescents and older children. And you can see this classic meniscus shape of the pleural fluid. It's probably a transudate. The underlying lung does not look like it's involved. And this is classified as non-severe disease as it's a simple effusion. There are no features of complications here. By contrast, this pleural effusion, which is also on the right-hand side, is associated with lots of underlying opacity in the lung. So this looks like underlying consolidation of the right lung, and for that reason would be classified as a complicated effusion and severe. Here's an example of a loculated effusion, and if you just note the shape of this effusion, it doesn't have that classic meniscus shape that we saw with the simple effusion, and this gives the impression that the effusion has become loculated or organized. There's also underlying involvement of the lung parenchyma on the right. You can see the whiteness on the right here. So this would also be classified as a complicated effusion, and this child should be treated for 6 months. Okay, this is one of the very classic TB chest X-rays that I hope we don't see too much anymore. We certainly don't see that much of it in South Africa as we used to, but this is miliary TB. So you know that this is TB that has now entered the bloodstream and disseminated throughout the body. And you can see the bilateral diffuse nodular infiltrates on this chest X-ray. And this child should certainly not be treated for 4 months, and one should be very careful to check for TB meningitis in a child presenting with such a chest X-ray. And now we're moving on to cavitary disease. So you might get cavities. There's several sort of X-ray patterns in TB that can give you cavities. And this is an example of primary progressive disease where the child had primary TB that was uncontrolled and untreated. And you can see cavity formation on this side. And you can also see that the TB has probably spread either directly in the lungs or via the bronchi to both lungs. So you can see the consolidation involving both lungs. So certainly involving more than a lobe. And this is severe. Another pattern of cavitary disease is one that you see more commonly in older children and adolescents. And this is reactivation or post-primary TB with a more adult type TB picture on chest X-ray, with cavities in the upper lobes and the apices of the lower lobes. And there's also consolidation bilaterally. So there are 2 reasons for this chest X-ray to be classified as radiologically severe. I just want to come back to the consolidation, just to show you an example of a lobar consolidation where there's dense opacification of the entire right upper lobe, compared to a segmental opacification where you can see here this whiteness on the left, in the left lung here, which is clearly involving less than a lobe and would be non-severe, and this child could be treated for 4 months. Here's another example of segmental consolidation. This is a child you've decided has TB. You review the chest X-ray and you can see this opacification, this consolidation in the right upper lobe, but with sparing at the top of the lobe. So this is also a segmental opacification, which is classified as non-severe. So in summary, I know that was a bit of a whirlwind trip through chest X-rays, but in summary, as per the latest WHO guidelines, we now know that a child with this chest X-ray compared to a child with this chest X-ray does not need to receive the same treatment. So children with non-severe TB can now receive a shorter treatment regimen. And one should use the chest X-ray before starting treatment to really try and exclude those radiological features of severe disease so that you can decide whether you should treat children for 4 versus 6 months. I'd like to thank the organizers for the invitation, as well as all the people who helped teach me how to look at chest X-rays, the Union team, the SHINE trial team, and of course all the children from whom these chest x-rays were taken. I am not sure, Ben and Kerry, whether we have time for the polls. I think we might be running a little over, but we can give it a shot if you think we have time.
We have a little bit of time. So
Okay,
I
that'd
think
be
we
great.
could, yeah, I think do you agree, Ben? We could go to the polls?
Yes, please go, Megan.
Let's go.
Okay, we've got 7 x-rays to look at, but we can just stop as soon. You just let me know if we need to stop. Caroline, will you share? Okay. Okay, so for each of these chest x-rays, we're going to ask you the same question. Does this chest x-ray show severe or non-severe disease? And it would be great to see and get as many of you to answer as possible. We hope we can all build confidence in classifying disease severity on chest x-ray going forward. Okay, so we've almost got 100 people voting. I think 300 people currently online. So have a look at the chest x-ray and let us know what you think. Is this severe? Remember the features of severe disease. Is there narrowing of the airways? Is there consolidation that involves more than a lobe? Are there any cavities, miliary infiltrates? I think if we get to 150, then maybe we can move on. Okay, so it looks like the majority of you at the moment say this is non-severe disease. Okay. All right, I think we've got 50% of people having voted. So I agree with you. This looks like non-severe disease. I would say that it looks like probably perihilar infiltrates or even a normal chest x-ray. And I didn't see any of the features of radiologically severe disease on that chest x-ray. Thanks, Caroline. We can go to the next one. Okay, so let's have a look at this chest x-ray. So let us know, do you think this looks like severe disease or non-severe, or do you still feel like you don't know? Almost 300 people who can vote, and we've got votes from almost 100. Okay, I think once we reach 150, then we can sort of summarize. So far, it looks like the vast majority of you think this is severe disease. Okay, so remember, on this x-ray, there's a very clear opacity on the left-hand side. So it looks like a consolidation in the left lung. And I would agree that this is severe disease because that looks like it's involving at least the whole lobe or more. Okay, so the vote there was for severe disease, and I agree with that. All right, Caroline, we can have the next one. Okay, so we have another chest x-ray. This time we're seeing an abnormality on the right-hand side. So let's see if we can get to 150 votes. Let us know. Do you think this is severe or non-severe, or do you not know? Okay, so remember, look at the airways, look at how much of the lung is involved, look for cavities, miliary infiltrates, and complicated pleural effusions. Okay, we've almost got 150 votes. Okay, so the most obvious pathology on this chest x-ray is the consolidation on the right, which looks like it's at least involving a full lobe as well. So I would classify that as radiologically severe.
Good afternoon, Delby.
Okay, thanks, Caroline. We can get to the next one. The fourth chest x-ray. Okay, all right, so x-ray number 4. So those last two, where there was quite a consensus on that it was severe disease. Let's see what people think about this chest x-ray. Okay, remember, go through all those features, make sure you've checked the airways, if there's involvement of the lung parenchyma, look at whether the consolidation is more than a lobe or not, look for cavities, miliary infiltrates, and look for complicated effusions. Okay, so we almost at 150. I do realize I'm not sure on your side, but the x-rays maybe not quite big enough to see everything so clearly. But if this x-ray was a little bit bigger, you can very nicely track the airways in this picture. So the airways look open, there's no airway involvement, but you can see a left hilar lymph node and essentially sparing of the lung parenchyma. So I agree with the 69% of you who called this non-severe. I would call that uncomplicated lymph node disease. Yeah, I'd be interested to hear in the chat, those of you that thought that was severe. Perhaps you thought there was involvement of the airways, but you're welcome to add your thoughts to the chat. Caroline, we can go on to the next chest X-ray. Ben and Kerry, just stop me if you need to.
You're fine, Megan. Yep, no problem.
Okay. All right, X-ray number 5. Okay, let's see if we can get to 150 votes. Do we think this is severe or do we think this is non-severe? It's very interesting for me to see these results as well, because I think some patterns are far easier to agree on than others. Okay, so we've got 120 votes, nearly 150, with over 90% of people classifying this as severe. Okay. So I agree, this looks like a large cavity you can see in the right upper lobe of this chest X-ray. So remember, if you see a cavity, then it's radiologically severe disease. So I agree with those of you who called this severe. Generally, cavities are something that's a little bit easier for people to agree on. This sort of inter-reader agreement is a bit better for cavities than for some other features. Okay, 2 more X-rays to go, Caroline. We can put up number 6. Okay, I suspect this one might be a little bit trickier for people. Okay, let's see what you think. Severe or non-severe disease? So remember, we're looking for any airway involvement. If there's consolidation, we need to decide whether it's segmental, less than a lobe, or involving a whole lobe or more. And if there's a pleural effusion, is it complicated? Do you see any cavities or miliary infiltrates? Okay, let's try and get to 150 votes. We're nearly there. Okay, so my suspicion is that one of the hardest radiological features to train on and to agree on is the extent of parenchymal involvement. And certainly, as one of the people on the SHINE trial that was having to do this, wasn't always easy to decide how much of the lung how much of the lung parenchyma was involved. So the way I see this chest X-ray is that there's a segmental opacification of the right middle lobe. So I would have classified this as non-severe. It's not so easy to see the airways, but I think the airways are patent. I've seen this X-ray a little bit more zoomed in than you all have. But this is an interesting one because I see actually the majority of you thought this was severe disease. Okay, and then the last chest X-ray. Okay, so last chest X-ray. Let's see if we can get to 150 votes, severe or non-severe. Okay, so look at the airways, see if you think the airways are open. Look at the lung, see whether there's any consolidation and how extensive it is. See if you see cavities or miliary infiltrates, and look for complicated effusions. Okay. So I think the most obvious pathology on this chest X-ray is that opacity sitting in the right hilar region, which is probably a lymph node or possibly just a segmental opacification. And this X-ray I would classify as non-severe because I think the airways look open and the lung involvement looks like it's less than 1 lobe. But I see 30% of you thought this looked severe. So let me know in the chat why you thought that, and we can discuss it. I think probably the extent of lung involvement is one of the trickier aspects in chest X-ray interpretation. Okay, that's it from me. Thank you, everybody. I'm happy to take questions.
Great, thank you very much, Megan, and thanks to everyone who participated in the polls. I think people like these sort of clinical polls, so that's a great presentation. Yeah. We have about 2 minutes for questions before the next presenter. So I can just pick out one question here, Megan, that you might not have seen. Peritracheal lymph nodes, can they also mimic lymphoma in children? That question actually just came through to me from Asif Muhammad. Thank you.
Okay. Yeah, absolutely. So I think that's a really excellent question. So absolutely, if you see a peritracheal lymph node, particularly if you don't see any other perihilar or subcarinal lymph nodes, then a lymphoma must be in your differential. So you should be very careful in a case like that and try and find other evidence for TB before just attributing the X-ray to TB.
Great, thank you very much. I'm just looking, some other questions have been answered in the chat. Annika, I don't know if you wanted to speak to your point about having the lateral.
Yeah, thanks, Megan. a great presentation. I'd rather keep on reading X-rays the whole day than having to talk about DR/TB treatment next. This is really great and interactive and fun. My point was just about the use of the lateral and how much value that adds, you know, and from data in the literature, it suggests that when detect a significant proportion of mediastinal lymph nodes, if one did not have the lateral, if you actually add the lateral, it has considerable value.
Okay.
I think it's also really important to encourage, if someone's going to go to the effort of doing an X-ray, to number one, do it well, check that it's good quality and that it's readable, and number two, actually get a lateral as well.
Yeah. Yes, I absolutely agree. And okay, there are some people who still don't believe in laterals, but I think those of us who've been trying to find lymph nodes on X-rays for a long time, I think there really is a benefit to the lateral to identify lymph nodes, but it also gives you certainty regarding what you've seen on the AP. So I think it can really help you to confirm what you've seen on the AP. And of course, with deciding how much lung is involved, it can also help you there. Particularly for nodes, I would always encourage people to try and get lateral X-rays if they can.
Great, thank you very much. And I think that's answered Tenzin's question as well, which is what is the role of the lateral chest X-ray? So I think that's also responded to that question. So thank you very much. I think we might move on because we're right on time. So it'd be nice to keep to time. So I might hand back to Ben. Thank you. And thanks so much, Megan, for your presentation. It was
Thanks.
great.
I'll go through the chat.
Thanks, Kerry, and thanks, Megan. Yes, we're right on time for our final speaker. And I want to introduce Anneke Hesseling. She's a distinguished professor at Stellenbosch University, and she's also the director of the Desmond Tutu TB Center. Anneke is going to reflect on treatment of drug-resistant tuberculosis in children. Anneke.
Thanks so much, Ben. Can you all hear me?
Yes.
Great.
Yes,
So I'm standing between you and your late supper or your late brunch or your late lunch, whatever it is. So I'm going to be try and not bore you, and also think it's important that we have time at the end to discuss on the many interesting questions that have come through in the chat. And so thanks to all of you for attending and hanging in there. It's very brave. Well done. So the topic I'm addressing is what's happening in the rapidly evolving landscape of DR/TB treatment in kids. And as Simon Scarf, my kind of colleague and mentor, recently said, yeah, things are becoming quite confusing, you know, guidelines, evidence, and routine care knowledge in the case of DR/TB. But I think the good news is a lot is happening, a lot of progress is being made. And the main questions are, how can we ensure that these benefits from advanced research are also translated to children, adolescents, and obviously down the line also to pregnant women. So I think it's important that we note that we can't talk about treatment if we don't have children that we've diagnosed appropriately. We've heard about the massive diagnostic gap for DSTB or TB overall, and it's probably as big, if not bigger, for DR/TB. I'm going to show you data to show you that kids with DR/TB do extremely well on TB treatment, but the biggest challenge currently is that too few children are actually diagnosed and detected and recorded and reported. And it's important to note that we should expect that the vast majority of children with DR/TB should be clinically diagnosed as kids with DSTB. And which is, so the bottom line is treatment is one aspect of the care cascade, but if you haven't accessed care and you haven't received a diagnosis, which should be a clinical diagnosis in the vast majority of kids with DR/TB, and the younger, the more likely, then they can't access the treatments which are thankfully progressing, and but there have been massive advances made over the last couple of years. This is a slide from James Seddon, but just to say these are really estimates of the number of children below the age of 15 with DR/TB or RR/TB or MDR/TB globally. These are estimates, but we don't really have good data, and surveillance data is particularly poor for DR/TB. For DR prevention, there's no data at all. That's not a captured TPT indicator. So it's a relatively small number of actual children of the total burden of disease compared to DSTB, but more complex to treat in terms of the regimens, and also these children and adolescents tend to come from more complex households. So this is data from a large, we thought that was large at this stage, almost 1,000 children, where we looked at global data collection of kids routinely accessing DR/TB care and treatments. It was across 24 countries. This data informed WHO guidelines, which have then recommended injectables sparing regimen should be a priority going forward. But you can see that kids here, and this was before we even had levofloxacin or moxifloxacin routinely in care with old drugs, old regimens, long and toxic, that almost 80% of kids with DRTB had a favorable treatment outcome, and those were clinically diagnosed, who would obviously tend to have less severe disease in general, had an almost 90% favorable treatment outcome. So these were children and adolescents, but primarily children below the age of 15. So in the old era, with the inferior drugs we had, children can be cured of DRTB. The issue is actually the long and the complex regimens and the poor safety profile and poor tolerability, especially when we still used injectables, and no one should be using them going forward. So what are the basics? Looking at the new operational guidelines and the new, handbook and the new guidelines, which we've heard from Sabina and Kerry today, the principles are really the same for kids and adults, but just the basics are really, the decision on the appropriate regimen should be based as on your clinical judgment. You see the whole child in front of you in the context of their family. And you should also consider what's practical and what preferences there are that are relevant and reasonable. And looking at the severity of disease, and we've heard beautifully from Megan how to look at that on X-ray, the site of disease, going to treat CNS disease different for RRTB than pulmonary disease. Of course, the DST, in most cases, will be that of the known source case and not of the child, because the minority of kids would be confirmed. And then, of course, the risk of adverse effects, tolerability, and then obviously what you have available. And if you don't have available, you should advocate and advocate based on your local data, which is an incentive to collect better routine data. So obviously there's a spectrum of disease in children as in adults. This is an example of CNS disease, and this miliary tuberculosis is extensive disease on X-rays, you've heard, and that these are forms of more severe disease and also extrapulmonary disease, including TB meningitis and spinal TB, which would really merit different treatment considerations. And then you've heard from Megan about the looking at whether it's TB or not, and then how severe it is on X-ray. And this will help you with the diagnosis. And it doesn't matter whether it's DS or DRTB, the principles are exactly the same. And then how severe the disease would influence inevitably how long you would be considering treating the child. And obviously it's a measure of also looking at the X-ray for your treatment response for follow-up. So you've heard about the exciting new guidelines and everything that Sabina summed up in a small nutshell, a walnut shell. We've got guidelines, we've got an operational handbook, and then we've also had a rapid communication, which predominantly included adult and adolescent data. So that's the elephant in the room today, which I'm going to briefly address. But we've made great progress, but we're still behind the adults. Okay, so I want to share with you data from Benefit Kids. It's a large unit aid project, like Martina was referring to earlier today for CAP-TB. It's the same funder, unit aid. And this project really focuses on better care for kids with DRTB, whether they're exposed, infected, or diseased. And I just showed you that kids with DRTB historically responded really well before we had better meds. And we recently updated that effort. And then we had 24,000 children. We will share those top level data with you at the union in 2 weeks in an oral presentation, but essentially kids have excellent outcomes. The difference with this IPD was, and meta-analysis, is that we specifically focused on including adolescents as well, because they often are technically included in adult evidence synthesis efforts, but they're not many adolescents, and then it's difficult to tease out actually what the age was of those participants. So we specifically looked at children 0 to 19. So this updated MDR IPT is 25 times the size of the first one, and it includes children and adolescents, and from more than 40 studies and across the globe. I just wanted to share some top line results, just so that you know what to look forward to and what's informed the guidelines specific to today's discussion. One of the questions was whether one could recommend the use of bedaquiline in kids below the age of 6 and then laminate below the age of 3, as you heard from Sabina. And in fact, when we looked at a sub-analysis of our large study, remember bedaquiline and laminate were not recommended in those age groups. In fact, there were some children who had access to bedaquiline or laminate, and those in general, we showed that when kids access bedaquiline, and those were probably the sickest kids with the most extensive disease and the most extensive DST, that use of bedaquiline resulted in shorter treatment duration and less injectable use. So this is not efficacy data, but it's actually showing the positive impact of bedaquiline in kids routinely accessing it when it was not recommended. And obviously going forward, we'll have tons more data since it's now recommended. But we don't need efficacy data in kids if we have efficacy data from adults, which is very clear in the case of bedaquiline. And so what the WHO guideline process followed is extrapolation. And so in the case of bedaquiline, we looked at data from pharmacokinetics and safety studies. There was actually only one study that contributes to data in children below the age of 5. And we looked at PK and safety there. And in the case of delaminid, we looked at the phase 1/2 PK and safety study done by Otsuka for delaminid. And so we looked at PK and safety data, and we looked at what was from results from the IPD, and then we extrapolated efficacy, and that resulted in the wonderful recommendation, which Sabina shared with you, that kids below the age of 6, basically now from 0 to age 99 or 103, you may now access bedaquiline, and you may also access delaminid across all ages. And this makes it possible to construct and deliver and give an all-oral injectable sparing measurement in kids across the age spectrum. That's a major milestone. And it replies to all the pre-existing WHO recommendations. And I'm going to show some subsequent slides, but I'm not going to go into the details. It's just so that you have this for reference. And I'm sure that we'll be sharing these slides with you after the presentations. So now we're going to stop for a poll. I just have some fun. These are my favorite kids and the TB champ trial, actually. And they are triplets. So the first question is, in your country or where you work or your region, what is the current age indication for bedaquiline? Or do you have plans to adopt the updated guideline? And I'm not asking about the pediatric formulation, I'm just asking about the drug. There's an adult 100 milligram formulation and a pediatric 20 milligrams called dispersible formulation. Okay, so we're going to wait for about 150. Okay, I think we can stop the poll. Interesting distribution. Okay, all ages 15%, not used at all 6%. So some of the questions, I guess, could be a little bit confusing. Updating the guidance is being planned. That's just very encouraging. And it's encouraging to see that few people see that in-country regulatory approval is a barrier. This is WHO pre-qualified. All of these formulations can be procured through the Global Drug Facility at reasonable prices that are negotiated through the GDF. Okay, great, very interesting. And I'm sure that's going to look very different by region if we had to do a sub-analysis. We're going to go, I think we can stop the poll. Great. So in the operational handbook, you'll see what the so-called standardized or shorter regimen is. And I say shorter because it's obviously much too long compared to what's now recommended in adults. So that's the standardized regimen, 9 to 12 months. But you can see that it's got many medications, far too many. And that many medications are actually added to which the organism is not likely to be susceptible. For example, prosinomide and ethambutol, and a very high pull burden. It's also important to note that WHO has recommended that ethionamide for 4 months can be replaced with linezolid. So there are two options currently in the current version, which will need to be updated, as Sabina indicated. The standardized or the so-called shorter, which is we just call standardized. And then the next slide is really about the eligibility, but it's exactly the same for kids as for adults. So I'm not going to go into this in detail. So this is really just for your reference. But it's important to note that children with more extensive disease are excluded. And as Megan just showed you, quite a lot of kids, and if you had to look at the data, probably at least 40 or 50% of kids with DRTB would have extensive disease. So we need to look at the implications of who's actually excluded from access to these current guidelines. Okay, and then we've got the individualized regimen, which I won't call the longer regimen, and it's really using, prioritizing using your group A drugs, picking what you need from the group B drugs, looking at the DST, and then looking at the extent of disease and the site of disease. But it's really important that this is a moving target. I think there's a lot of confusion at the moment, and the terminology itself in terms of shorter and longer itself is actually quite confusing. So I think we should talk about individualized regimens, and this really looks at basically what the organism.
I didn't catch that. Could you try again?
Oh, Siri actually wants to cooperate with us. So you really need to look at what the organism is susceptible to, or what the source cases or likely source cases organisms susceptible to, the extent of disease, the site of disease, and then what you have available, and then obviously the treatment response, and prioritizing groups from drug A. And in 2 weeks' time, you'll see the results of the overall IPD, and you'll see the role and the value of using group A drugs, and the more of them, the better. And that's really the rest of the recommendations, which I'm not going to go to in detail, but it's also important to note that you may extend bedaquiline on an individual basis in kids like you may in adults beyond the 6-month period. It's important to note that the existing pharmacokinetic and safety data are quite small numbers still. So we need more data, and the more data we have, the more robust the science is on which we base our recommendations for dosing. I can just say that the current data, even with relatively high doses of bedaquiline in very young children, it's extremely safe from all aspects, including the kind of cardiac concerns, no concerns. The younger the children, the safer it seems. Safe in all kids. And then important to note about the role of linezolid, that it may improve outcomes for the full duration of treatment, but that is obviously the drug which is the most treatment limiting with regards to toxicity. And do not forget elaminid. We do not have pretominid in kids, and these are drugs in the same drug class. Although it's a group C drug, this is our substitution for pretominid, and it will be a long time before we have access to pretominid based on no data in kids currently. Okay, but many clinicians, and this is my personal opinion, not WHO's, prefer individualized regimens because it makes sense that you can look at, as we talked about SHINE, looking at not giving treatments that are overly long, overly toxic, and that you cover and you have at least 4 drugs to which your strain is susceptible, and that your continuation phase is more intensive and your maintenance phase covers adequately. So I think going forward, and in the field, many clinicians prefer individualized treatment regimens, and it's up to us to actually look at making sure that the next iteration of the guidelines reflect the best current evidence that we have. In the operational handbook, there's an example of what regimens could look like, just to be really practical. If equivalent is susceptible, the choice of regimen as an example, and you can see bedaquiline, levo, linezolid, there's your group A drugs. Delaminid is a group C drug, with consideration of clofazimine or cycloserine. Quinolone resistant, you obviously have to substitute your quinolone, and if quinolone resistant and bedaquiline resistant, you have more limited options. And this is what we currently have as suggestions in operational handbook for children. Treatment duration, again, I've talked about individualized care, and these are suggested, these are not prescriptive. And these also may change, but it's just important to note that the more severe the disease, and also especially if it's osteoarticular or in the brain, the longer you're more likely to have to treat. In routine care, many kids are receiving 6 to 9 months of treatment in routine care currently, but they typically have non-severe disease, typically peripheral lymph node or limited pulmonary disease. A short note about TB meningitis, there's limited evidence, but it's important principle again, just getting back to principles, the same in kids as in adults and adolescents and pregnant women. Look at the actual properties of the drug and whether they penetrate the CSF. There is actually emerging data on bedaquiline, but still needs to be verified. The laminate is actually concentrated in the brain, which is interesting. So that would be good to watch that space. But you can see which drugs actually have good penetration, which have poorer. And then in some cases, one might have to use higher doses if that's all you have available, or looking at the DST of the organism that you're dealing with, or of the source case organism. In general, levofloxacin, linezolid, group A drugs have extremely good CSF penetration, and it's hopeful that we'll get more data on bedaquiline, another group A drug, in terms of CSF penetration. But the delaminid is an interesting drug in the sense that it's concentrated in the brain, and therefore it's also linked to the kind of neuropsychiatric signal that we've seen emerging in young children. I'm not going to go into details. It's in the operational handbook as an annex, but as referred earlier, we have detailed dosing recommendations by weight band. These weight bands have been updated for the drugs, and with the formulations available in the field by drug group, drug A, group A. These are the details for bedaquiline. You can see it's quite detailed. So it looks at the weight as well as the age in the younger kids, because we have to consider developmental pharmacology. So a term 3-month-old may not be the same as a smaller 9-month-old. And the same is actually the case for delaminid. So the new updated weight bands are actually far more clinically relevant and efficient. They've been a bit more harmonized and they make a bit more sense for the adolescents. And this is now actually across TB. So this is the specific dosing recommendations for bedaquiline. And you can see also that you have an adult formulation and a pediatric formulation. If you do not have the pediatric formulation available yet, you should advocate for it, but it's not a train smash. There's very good data and published. It's in the operational handbook showing that you can actually use the adult 100 milligram tablets. You can dissolve it in water and give the relevant amount as liquid to the child with a bit of a rinse. It's completely bioequivalent to the pediatric formulation. So there's no formulation effect. There's no effect on bioavailability if you dissolve the adult tablet into water. And obviously it can reduce the pill burden in somewhat heavier kids. And again, the group B and the group C, here are the dosing tables. They're all in the annex. I think it's annex 6. And then the detailed recommendations for delaminid. Remember, as Sabina said, these are provisional dosing recommendations because there's not a huge amount of data, but we can extrapolate efficacy. We have PK and safety data. And as more data come out, it's incumbent upon all of us to generate more data and to combine those efforts and join and pool the data so that we have the best data globally. And then you can see for the other groups, and we hope not to see injectables on there unnecessarily, but just for completeness sake. So where are we now? The talk was really what is rapidly evolving. So these wonderful guidelines were issued for peds TB and adolescents in March on World TB Day. And then in May was the adult guidelines. Now we have BPAL and BPAL recommended in adults and adolescents down to age 14 or 15 respectively. So now we have a 6-month all oral regimen in adults who typically have more extensive or have more bugs on board. So they're typically not paucibacillary TB compared to kids. And we have BPAL, which is 3 drugs if you're quinine resistant. So now we are really lagging behind in terms of where we are with evidence and guidance for kids. And then we still have a recommendation to use the 9-month oral bedaquiline containing regimen. But there's really a dramatic gap for kids. And one of the big reasons is really that we have absolutely no data on predominant. The pediatric studies were very much delayed, are only starting now as single dose studies. And that was because there was potential safety signal regarding testicular toxicity, which is really unfortunate. But you can see now that programmatically it's already recommended for adolescents in routine care. So now we're behind again. So how have we rapidly evolved? Just as a recap, we've got the updated WHO guidance on the management of many new indications for TB, but including RRTB in children and adolescents in March. We have PK and safety studies, which are contributing more data as we speak, which will be shared as soon as the global community can generate those. We also have data emerging on new and repurposed drugs and also their optimal dose, for example, clofazimine. There's no formal published clofazimine data in children, and we really need to verify that we're using this drug well, especially considering the tolerability and the safety aspects. There's a data gap for predominant, and clearly there's still some gaps on child-friendly formulations, but here we've made rapid progress considering the really poor progress that had been made in the past 10 years. And then the whole issue of duration of treatment. Now we've got a 6-month regimen recommended in adults and a 9-month regimen recommended in adults, even with XDR or pre-XDR TB. And now we're having children with paucibacillary disease with a longer treatment regimen recommended, which is a little bit out of sync. So how can we be forward? And this is almost at the end. We need better regimens for kids with DRTB or MDR-TB and have not addressed INH-resistant TB. So we have emerging evidence from multiple adult trials. Some of them have included a couple of adolescents. The BTB trial includes some children, but the youngest kid has been enrolled has been 8 and only a handful of kids. We have new recommendations, as I've shown, that it's based on all of these trials, including a 6 months of 4 drugs or 3 drugs, and 3 drugs if you have additional resistance. And then we have pediatric caps for predominant, which will take a while to address. And there's some current alternatives which are recommended, but 9 months may not be, or 12 to 18 months might not be first prize in kids, but that's where we currently stand. So just moving forward, what could an ideal regimen look like for children? And this is a protocol which is currently in development, not funded yet. It's called Smart Kids. And the idea would be, it's a very similar regimen compared to what's currently being evaluated in the BTB trial. But this would be a 6 months oral regimen that really is the pediatric equivalent of B-Palm. So we'd use 6 months of levo, bedaquiline, delaminid, and the linezolid, but only for 8 weeks. The linezolid sparing because of the toxicity, and it's really real in kids. And then if there's quinolone resistance, to switch the levo to clofazimine. And this would be primarily a safety and tolerability study. And the innovations that we would actually plan to add here are including kids across the disease spectrum. I would also substitute predominant for delaminid, or because that's what we had, and it's the same drug class, and there's no evidence that predominant is superior to delaminid. And we'll see the BTB data shortly, which will probably verify that. And the idea for this regimen is also to keep it really simple. Everything will be given once daily for 6 months, apart from the loading phase of bedaquiline, which will be the 14-day, the 2 weeks loading phase. Everything once a day, very simple. And then just linezolid sparing. So they are really important because this really is a toxic drug. We need oxazolones that are safer in TB patients overall. So looking at the pipeline, what's coming forward, there's an example of 2 potentially safer and as efficacious oxazolones, delpazolate and cetazolate. These are the drugs we should be planning to evaluate in kids and where we need formulation sooner rather than later. But you can see there's a lot that's coming through, and we should be thinking earlier on now. Are we going to better and earlier address these research gaps? And then we still have this glaring, massive predominant research gap. The study that's planned to open early in 2023 is a single dose PK and only will be in female, so only in girls. That's only what the FDA would allow. So that's truly unfortunate, but that's the reality, and at least will generate some data. But there's some really amazing other drugs in the pipeline. We need to think of regimens that are going to be child, adolescent, and patient and family friendly. Okay, so just a brief note on formulations. I just want to acknowledge the massive amount of progress made in the field. We now have 11 child-friendly or almost child-friendly formulations available. And these are listed there for you, and these are all accessible through the GDF. And I want to acknowledge the Sentinel project for their hard work, and also UnitAid and others for helping fund some of these efforts. It does not necessarily mean that these formulations always taste delicious, but we have pediatric quality insured, registered, and WHO approved formulations available for all of these drugs, including bedaquiline, linezolid, and delaminate, so the new drugs as well as the older drugs. So that's remarkable progress, and I think we should all embrace this and move this forward in the field. However, I mean, we have fixed dose combinations. That's 1 tablet for an FDC for drug susceptible TB. This is the McLeod's formulation, which has been in the field now for several years, used in SHINE. And we still have multiple tablets and multiple combinations for kids. The good news is we have, this is an example of bedaquiline. This is really a Mercedes-Benz pediatric formulation. This is a dispersible scored, functionally scored. So it means like half of the drug is in half of that tablet, and it tastes like nothing. And 5 of these tablets are completely equivalent to one of these 100 milligram tablets. So that is a functionally scored dispersible, so it dissolves in water quickly. This is delaminid, and we've also shown that you can crush delaminid, dissolve it in water if you don't have the pediatric delaminid formulation. So this is an example of extemporaneous formulation. And we've also done a study similar to bedaquiline crushing, that you can crush delaminid, and there's no effect actually on the levels of the drug that you get in the blood. So basically, if you don't have the pediatric formulation, you should advocate for it. But for both bedaquiline and delaminid, you can use the adult formulations. And in the operational handbook, there's specific instructions on how to do this and videos and resources to share. So last poll question, in where you work, or where you think you work, maybe you work globally, Which child-friendly formulations are available, if any? And so the answers are, sorry, that is the wrong poll question. This is the question for, okay, I think we've got a laminate here. That's fine. I think we can skip this poll because we're going to go over time. Well, let's continue. People have answered. Let's continue with the poll. The question is actually how many people have delaminate accessible in your country? Who has access to delaminate? Adult or pediatric formulation? So in which age groups do you use delaminate? So based on the new WHO recommendations to include it in its use in children below the age of 3. Okay. I think we'll give the poll another couple of seconds. So continue voting, please, if you don't mind. An important question is also whether you're planning to update your guidelines. It doesn't mean that you will necessarily have the pediatric formulations in country, but the use of delaminate in kids. Okay, great. I think we can close the poll now. We've had a nice turnout. So all ages, 14%. Is not used at all, 11%. Again, very few in-country regulatory barriers, and then planning to update 30%. So we're going to see some action here, and we're going to see more access to delaminate in kids below the age of 3. Thanks. We can move on. This was actually the poll question that I had in mind. So I'm going to let you poll on this again. Which of these formulations do you actually have where you work? Or all of these or none of these? Levo, moxie, bedaquiline, adult, bedaquiline, peds, clofazimine, cerazodone, or cycloserine, delaminate, pediatric, isoniazid. What do you have available locally or in your program, or what you know you can access where you work? Okay, I can't see the poll. So Caroline.
Anneke, the poll is actually, we don't have that last question on the poll, so maybe people can just write in the chat.
Put it in the chat.
Thank you.
Yeah. Okay, let's wrap up. So just to say that in terms of the formulations, there is also ongoing data looking, formulations matter, and so not all formulations are equal. So it is important to look at formulation effects. There are trials, including trials from the Benefit Kids studies or portfolios that are looking at the effect of different types of formulation, for example, levofloxacin, also of the new generic moxie and clofazimine formulations, PK safety and tolerability and acceptability. And then we have talked briefly about DRTB prevention. So there's ongoing work, and it's important that we actually look at different formulations and not just whether they are in child-friendly sizes, but also whether they taste good and that they're actually child and family friendly. So an example of actually just how to move the field forward is the ChildPrep study. There's a link to the video, and you're welcome to look at that. Very brief. And this is a study where we went into the field and asked children themselves across really wide dietary preferences and ethnic cultural preferences, which formulation taste that they prefer. And this was specifically for moxifloxacin and linezolid. These formulations are already developed. The aim was to actually pick up the best taste to be able to do optimal taste masking, where children actually literally ranked and scored their preference of taste and why across age groups and across kind of different dietary groups. And I think this is really a nice way to be able to engage children going forward, not just for TB, but across all disease areas, to make sure that formulations actually taste acceptable as well as are dispersible and are in small sizes. To end off, DR prevention is also key, and prevention is always better than cure. We expect that WHO will convene a GDG in 2023 to update the current DRTB prevention guidelines. This is what's currently recommended for your references in 2018. It didn't really change in 2020. But there's really a conditional recommendation to low quality of evidence to consider using individualized preventive therapy for individuals that are high risk exposed to DRTB. But you can see that there are many requirements, and there's really almost no implementation of this on the ground in routine care because it's a conditional recommendation based on low quality of evidence. There are trials that will actually address this data gap, and these data are forthcoming. The first data that you'll see is VQuin, and hopefully in the next couple of weeks, a study implemented in Vietnam using levo versus placebo, then a pediatric study, TB Chump, data coming out next year, and these data will be combined, and then another study looking at Elaminid. And all of these are household-based studies looking at cluster randomized trials to do look at selected high-risk groups for DRTB prevention in household contacts, since no randomized clinical trial has been conducted in this domain. So next year, hopefully we'll have more data and we'll be able to do more about this as a global community. So I wanted to thank colleagues, collaborators, contributors, really also children communities we work with, our community, our DTTC CAB, and all of our funders. Thanks very much.
Thank you, Annika. That was a very comprehensive overview for everyone to know what's happening on the DRTB front. Just one quick question before we ask some questions to our other speakers as well. I think you've covered the contact issue, but whether you've got any information to share about bedaquiline CNS penetration. You said data is emerging, but is there any?
I'll put the reference in the link. There's a proof of concept study recently published by Karen Apton from Task in Cape Town that shows that bedaquiline is detectable on the CNS in adults. And the question will be actually then what is the appropriate dose and what levels are achieved and whether they really are therapeutic. But there's more work that's ongoing, and I can post what's already published in the public domain in the chat.
Thank you. That would be useful. I'm going to maybe just ask a quick question to Sabina, and then we can run through the outstanding questions in the last 5 minutes that we have. Sabina, I wondered if you could maybe just clarify to people what the method of choice would be for stool testing using Expert Ultra, just briefly. What
Sure.
are all the options that are available?
Sure. Thanks very much, Ben. So for the guidelines in the handbook, there were some data that were reviewed on different stool processing methods, and basically we have some information about two methods. Which one of them is the optimized sucrose flotation method, which is the one that was used by TB Speed, and the other one is the simple one-step stool method, which was the one developed by the KNCV Tuberculosis Foundation, and both work well. Both can be used in programmatic conditions. And some of the sort of more qualitative research showed that the simple one-step stool, the SOS method, is probably the easiest to implement at lower level laboratories. There's also a very nice stool processing manual that has been published, and I will post the link in the chat so that people can access that. There's much more information about, say, the laboratory side of things, of how to use Expert Ultra on stool samples. I hope that that's useful.
Thank you, Sabina. I'm going to hand over to Kerry to maybe ask a few additional questions.
Sure, thank you very much, Ben. I'm just scrolling through the chat to see if there are any unanswered questions. I think a few of them Annika answered about the high toxicity of bedaquiline. And we also, Annika, I think you also answered the question, which was twice in the chat, about preventive regimens for children who are in contact with someone with drug-resistant TB. So that's good. There was another question from Mo Torkau about bioavailability of second-line TB drugs in cases where the dispersible tablets are not available, even though this is optimal. How many days can we split or crush tablets without worrying about bioavailability? And yeah, this person acknowledges that this is not an optimal situation, but perhaps the
but I think you have to do the best with what you have. And so I think this is where the extemporaneous formulation data is really useful. In the operational handbook, there's some annexes that actually show you what you can do. And we can also, after this talk today, share the links with you on videos on how to make an extemporaneous formulation. There are some articles that will be published shortly, 4 or 5, showing that you can actually take your adult formulation and with a simple syrup that's cheap and safe, make a suspension temporarily for use that's actually stable and effective and uncontaminated for, a couple of weeks. So that's kind of a how-to in the field. And I think it's important that we do this, but it shouldn't actually discourage us from advocating and accessing truly child-friendly formulations. But I think often in neonates, that's what one would often do anyway, or people that get NG tube feeding. But the extemporaneous formulation we can compounding with is a nice bridge in the field. And there's some further work planned to look at whether there would be devices that would make that process easier, and potentially whether you could even combine drugs and put it in one device and then give it. But one would then need to see whether there are actual interactions between these different medicines. But for example, drugs like clofazimine, bedaquiline, delaminid, key second-line drugs, one can actually do extemporaneous formulation in a very affordable, very simple way. There will be a reference and SOP on how to do that in the field. And a nurse could do that who would not have to be a pharmacist in a hospital.
Mm-hmm. Great, thank you, Annika. And I can see Tiziana's added a comment about an information note that we're also developing, which will include some of this information on sort of practical administration issues. Perhaps another question. I can see 2 questions about ECG.
Question is yes, like in adults, you want to routinely an operational handbook. There's some guidance. It is really important to make sure that you have a good baseline. And I can say that triplicate ECGs are not useful. One reading is good as long as you do it well. You should use the Frederica correction for QTCF, obviously. Mm-hmm. And regular monitoring is important. There's a suggested schedule actually outlined in the operational handbook. Yeah. It's important to actually exclude baseline QTCF prolongation, and family history of cardiac issues, is important. And then just getting a child to lie still, I think that's probably the trickiest bit. The smaller the child, the more movement. But it's quite feasible to do ECGs in routine primary healthcare clinics. It happens on routine. It's not actually a barrier.
Great, thanks. Thanks, Annika. Good. Just checking for any other questions. There was a question earlier, I think it was for Eric. And this was from Dahafa Nanjebo. So this question is, how can we make screening of TB in children easier for community health workers and nurses, because these are the first team that will encounter a child with presumed TB? So Eric, could you comment on that question? We didn't get to that one earlier. Thanks.
Yeah, so I can comment on that question. The screening question, the way we thought that could make it easy in terms of practical terms is one, it's important to be able to understand from the context of the communities where you're working, whether some of these questions are stigmatizing or not. So it's important to understand what people feel about the question they're asking. And secondly, it's important also to understand whether to get an understanding whether the questions are complex. The way we did it, we actually had to split the questions into small bits. For instance, if you're asking screening questions about fever or cough, rather than saying fever for 2 weeks, you rather first find out whether it's fever at all and ask for how long, because that's less stigmatizing and it's less incriminating to the parents. So breaking those questions to small understandable parts was something that we did. And that's the experience that we have. I don't think I have any other easier way of doing it. And also, of course, the other issues is about privacy, which is also another challenge in terms of the questions being and where they're being asked.
Great, thanks.
That's what
thanks, Eric. Yeah, thank you very much, Eric. And maybe we have just a few minutes for one more question, maybe for, I think this was for Martina Kazengi earlier in the chat. And this is from Tenzin Ladon. So what is the role of PPD or MAN2 or skin testing in screening? So this is for contacts, I assume. Martina?
Thank you, Carrie. So as I mentioned in CAP-TB, we really focus on the target population for whom actually TST is not recommended. So we really focus on the high-risk population. So we don't have practical experience directly because we really didn't implement it. I think TST, and really I would welcome anyone to also complement on what I'm saying. TST comes into a role for the older children who are HIV negative. And that I would say what we have seen in the field is that it still remains a challenge to have it available. So perhaps is more, with the recently recommended new test for TST, the WHO, recently issued a recommendation. I think there is, it's worthwhile looking and doing operational research to see if the availability of this test has improved, and also the performance of this test. It's easier. Maybe there is a role there for the older children, but at the moment, with the tools we had available at the time the project started, we really didn't push it forward. First, because it wasn't recommended, and second, because the availability is still challenging. Yeah. And we wanted the screening to be as simple as possible, not to create a barrier.
Okay, great. Thanks very much. And yes, as you mentioned, there are some new guidance on antigen-based skin tests. We can put that into the chat, perhaps. I think I'll pass back to you, Ben, because we're at the point where we need to wrap up. So thanks, everyone.
Thank you, Kerry. And we just want to thank all participants and the speakers. I think we had a fascinating overview covering the breadth of challenges in the field, new developments, and practical guidance. Megan, I think your X-ray session, and especially the X-ray quiz, was greatly valued. And as countries are thinking about implementing the short course, 4-month treatment regimen for children with uncomplicated TB, that's going to be very practical. And I also just want to thank the whole WHO Child and Adolescent TB team. I think the handbook and the guidelines that's been launched this year is really an unparalleled resource for child TB. Clearly, there are many complex issues, but we now have better guidance than ever. And we've got more champions, which each of you on the call would represent in your countries to make sure that we implement the best possible care down to the lowest level of care possible, using whatever is appropriate in that particular setting. So thank you, everyone, for your contribution, but also for assisting us to move the agenda forward. But I'm going to hand over to Kerry, maybe just for a final closing word, and then to the organizers, if they have any final messages.
Yeah, sure. Thank you very much, Ben. So I'd like to thank you for co-chairing this session, and to the speakers and the organisers, including the staff from the union and our team in the Global TB program, who have been behind the scenes but answering some questions and have provided support. So yeah, just thank you to everyone. Thank you to all of the participants. I think we still have 260 people online, which is great. And thank you for all the questions. There have been several questions about whether we will share the presentations. If the speakers consent to that, we can certainly make those available. And I think I will hand back to Caroline to finish. And yeah, thank you very much, everyone. It's been a really, really excellent session. So thanks.
Thank you, everybody. Thank you to all the speakers for attending the session today. Once this Zoom meeting closes, you will see a survey appeared on your screen. We would appreciate if you could complete to give us feedback on this event. The link will be active just for a short period of time, so you have to complete it pretty much as soon as it closes. Also, so the session was recorded. You will be receiving the link to the recording of the session within the next 48 hours. I also want to remind you that this session is accredited, so you can claim CME points for your attendance. And on behalf of the union and to our presenters, thank you very much for joining us today, and enjoy the rest of your day. Thank you very much.
Thank you.
Bye.
Thank you.
Yeah.
Bye
Thank
bye.
you.
Bye, everybody.
Bye, everyone.
Bye bye.
Thank you. Bye bye, everybody.